Good afternoon, ladies and gentlemen. So I'm going to have to get the procedural part here right. Bear with me for a moment. The recessed meeting of the Committee on Human Services will come to order. The Committee on Appropriation and Human Services will come to order. The Human Services roll call is an open roll call from a recessed committee meeting earlier in the week. There will be a new roll call for Appropriations Human Services. Will the clerk please call the roll?
Harris.
Here.
Gable. Here. Belloc. Here. Demmer. Here. Feigenholz. Ford. Freeze. Here. Hernandez. Jessel. Lilly. Manley. Here. Mayfield. Meyer. Here. Mussman. Here. Severin. Here. Spain. Willis.
And will the clerk please add Representative Lilly to the roll? So good morning, or good afternoon, ladies and gentlemen, and thank you for attending the second in a series of hearings. And if we get someone to shut the door so that we can keep the noise from the crowd. Thank you for your patience, and would the clerk please add Representatives Sauer and Spain to the roll. So start over again now they got that door shut and we can hear each other. Just wanted to welcome people back for the second in a series of hearings on the proposed or the ongoing request for proposal for managed care organizations in Illinois under the Medicaid program. This is the second hearing. We did have one hearing several months ago where there were numerous areas of concern and interest raised. Since then, there have been continuing discussions about this, and we felt it was very important to continue to give members of the public as much information about this proposal as is possible, particularly since it is the largest procurement ever in Illinois history, since it will be spending $9 billion of the taxpayers' money, and it will be redefining how health care is obtained and delivered in all 102 counties across the state of Illinois. And I think the figures are correct that in 72 of those counties, this system has never existed before. So in a period of months, we are recreating the healthcare system of Illinois, or at least a large segment of it, essentially from scratch. And I think it's incumbent on every one of us who is an elected official to understand how this process is going to work, how it will influence our local providers, our hospitals, our doctors, our pharmacists, dentists, all the medical professionals, how this will affect our communities, how constituents who are covered by the Medicaid program, which we know in the state of Illinois, 1 in 4 of our citizens are. So this is a monumental undertaking, and I think we should avail ourselves of every opportunity to learn of foreseeable and also potentially unforeseen consequences. And if you'll recall, at the last meeting, there were a number of questions raised during the testimony, and we're very thankful that Director Felicia Norwood of the Department of Health Care and Family Services came and spent a lot of time answering questions in the last session. She's here again today to provide more perspective. But the one thing I want to draw to people's attention is there was a list of questions that arose based on the testimony at the last hearing that came from both sides of the aisle. The day after the hearing, I put those questions into a letter and delivered that letter to Bruce Rauner, the governor of Illinois. So that was several months ago. As of now, I can tell you I've received no response, not one response, to any of those questions that were put in writing. And for your benefit, if staff can pass out, I brought copies of the letter with the inquiry that I sent to the governor so that you guys are aware of the questions that were asked based on committee last week. So I find that disheartening, to say the least, that the governor did not even have the courtesy to write a letter of response back. Maybe his chief letter writer is busy doing other things. But we're here today to continue to talk about the RFP and its effects. I know there are a lot of topics around the issue of Medicaid. There are a lot of topics around some of the folks who will be testifying today that do not relate to Medicaid. We're going to stick just to issues relating to the RFP today. We're not going to be talking about the Medicaid program in general. We're not going to talk about, as some witnesses, for instance, from Planned Parenthood or the ACLU come up and talk, we're not going to relitigate House Bill 40 in general. We'll be talking about issues directly related to the RFP that's in front of us. So with that, ladies and gentlemen, I don't know if Chairman Gable or Leader Belloc have any comments they'd like to add at this point. Representative Belloc.
I just wanted to welcome the Comptroller. I wanted to welcome the head of HFS, Felicia Norwood, and everybody else who's here to speak today. And as Representative Harris said, we have gone over this several times, but we're here again to go over it again. And so we're open to any questions and moving forward. Thank you.
And also, I just want to, before we welcome the Comptroller of the state of Illinois to open us up, I just want to thank her office for hosting, literally, I hear some 5,000 or 10,000 residents of Illinois for her annual Cheesecake Day. There are people streaming in and out of her office from all over our state, and in memory of our late good friend Judy Bartopinka. So. I'll now ask our first panel, led by the Comptroller of Illinois, Susanna Mendoza, to offer their testimony.
Well, thank you very much. And yeah, there's not much to smile about these days in Springfield, but you can always smile about cheesecake. So very happy to have hosted that today. I just want to start by saying thank you, Mr. Chairman, and the other distinguished members of the committees for giving me the opportunity to speak to you today. Our national healthcare system is undergoing a seismic shift as politicians in Washington, D.C. weigh a repeal of the Affordable Care Act. That debate has received a lot of attention, but massive changes to the healthcare system are underway here as well, with Governor Bruce Rauner pushing for an overhaul of the Medicaid system that delivers healthcare to every corner of the state. Earlier this year, using his executive authority, the governor directed his staff to initiate a process to restructure our state's healthcare delivery network and shift nearly 500,000 Medicaid recipients into the crowded managed care organization system. The Rauner plan will affect 3.1 million Medicaid recipients, as well as every doctor and healthcare provider in Illinois. His plan also comes with a huge financial commitment, with an estimated cost ranging anywhere from $35 billion to $40 billion over 4 years. It is one of the largest, if not the largest, procurement in state history. As Illinois' Chief Fiscal and Accountability Officer, my concerns over MCO restructuring start with 3 issues: timing, transparency, and accountability. Illinois has been without a budget for 23 months. It is in the midst of the greatest financial crisis in its history. The state's bill backlog exceeds $12 billion. And we owe more than $7 billion to healthcare providers, including group healthcare providers alone. Despite any programmatic changes, nothing alters the fact that the state does not have a budget, and the state's bills to healthcare providers will continue to be paid a year or more behind schedule. I worry that this undertaking could further limit our ability to support our failing social service agencies, universities, and other basic state functions. Right now, we need greater flexibility, not fewer resources and options, to navigate this ongoing crisis. With state finances in disarray and the future of our national healthcare system so uncertain, why is this the time to restructure managed care? I would argue that this is possibly the worst time to consider a major restructuring in light of the state's fiscal instability and the instability of healthcare at the national level. Since this proposed procurement is overseen by the Department of Healthcare and Family Services as a, quote, purchase of care, it is proceeding outside of the state standard procurement code. That means that this proposal is not afforded the same independent oversight as, say, a contract to purchase paper clips. The state's chief procurement officer isn't overseeing this procurement, and furthermore, as Director Norwood acknowledged during her testimony before the House Health and Human Services Committee, the top 3 executives from HFS have recused themselves from the process because of their ties to the healthcare industry. Even now, we don't know who's making the decisions about this massive procurement. Now, I was disappointed to discover that HFS did not learn from the mistakes of the Quinn administration when it labeled this procurement a purchase of care. The implementation of similar programmatic changes under the previous administration left a lot to be desired. The lack of transparency and of independent oversight led to a lot of problems and confusion for patients, doctors, providers, and others touched by the healthcare system. Why is this administration avoiding transparency for a proposal that will impact healthcare delivery to millions of Illinoisans? In a normal budgetary environment, the General Assembly serves as a check on state functions through the appropriations process. However, this rushed procurement will be funded on an ongoing basis through appropriations currently mandated by court order outside of the purview of the General Assembly. In other words, as long as there's no state budget, there's no General Assembly oversight of this critical state function. Additionally, because the Rauner MCO restructuring plan is an executive order and not a bill, our legislators won't have an opportunity to debate it, much less vote on it. All of you have been, by design, cut out of the process. It's an end run around the General Assembly. So who will be accountable when there is a problem? Now, I'm most concerned about this proposal's impact on the lives of Illinois' most economically challenged. Let me remind you about who receives Medicaid. It's the most vulnerable people in our state. Most beneficiaries are managing serious disabilities and illnesses that severely impact the quality of their lives. These are the very people who can't afford to hire someone to be their voice. I take it upon myself to be their voice, and I would certainly hope that the legislature would do the same. This much is clear. The current proposal seeks to increase participation in MCOs by about 25% over a larger geographic area than what is covered now. At the same time, it seeks to reduce the number of managed care providers by as much as 2/3. They say the devil's in the details, and we need to dig into the details of this RFP to determine how this change could impact individuals. For example, the model contract would require that some managed care recipients travel as far as 60 miles to the nearest pharmacy that will serve them. For people who can't drive or don't have a friend or relative who can help pick them up to go purchase their medication, that might as well be 1,000 miles that they're driving. The goal should be to help people manage their illness by seeing their doctors and getting their medicine, and not ending up in an emergency room, which, by the way, is both morally and fiscally unsound. My concern is that every Illinoisan, wherever they live, has access to the same quality of care. It is not right that people of central and southern Illinois could be disproportionately impacted in a negative way in the rush to ram this through. The people in Marion and Peoria deserve the same consumer protections as people in Winnetka and Chicago. Medical studies from the early 1990s, through the passage of the Affordable Care Act, have attributed a death toll to the lack of health insurance coverage. Now, in April, the governor said the following, quote, "I believe in competition and opening up markets as much as possible. Competition can increase quality and drive down cost. So making sure that people have choices and they're not locked into a monopoly or one limited market, I think, is generally a good philosophy in every aspect of life, including healthcare," end of quote. This proposal, by design, limits competition. Studies support the assertion that competition is good for consumers who get to choose from multiple healthcare providers. Insurance premiums have increased at a statistically significant rate over the last 3 decades at a time of unprecedented healthcare industry consolidation. So the more I look at it, the more I'm convinced that this is not a consumer-friendly initiative. Everything about it says top-down when it should be user-driven. This proposal appears to favor the giant MCOs and healthcare conglomerates at the expense of the most vulnerable people in the state of Illinois. Moreover, there's evidence that similar initiatives advanced without appropriate questions being raised have been met with unforeseen challenges, including reduced access to service, increased administrative costs, and massive lawsuits. Instead of learning from those mistakes, the administration is doubling down, and it has all the makings of a botched rollout just waiting to happen. We have an opportunity to do right by those in the Medicaid system. Hearings are a start, but let's also take time to evaluate the current Medicaid and MCO systems and determine how changes in Washington, D.C. could affect healthcare right here in Illinois. We need time to ask questions and time to get answers. Let's consider auditing the existing system and fixing what we have before restructuring it. Then, at a later date, we can consider additional changes that could save money and improve services to managed care recipients. I've personally reached out to representatives in Congress and the Senate to share my concerns about our constituents, and I certainly hope that others do the same. Again, as Illinois' Chief Fiscal and Accountability Officer, my concerns over MCO restructuring start with 3 issues: timing, transparency, and accountability. I firmly believe that ramming this plan through without independent oversight is not in the best interest of the state's more than 3 million Medicaid recipients. There's no legitimate reason to rush. This will have lasting budgetary financial implications for the state of Illinois, and they will not necessarily be good ones. Again, let me remind everyone, we don't even have a budget in place, and the administration is trying to ram through one of the largest procurements in the history of this state. We need to stabilize the state's finances first. At that point, if and when it's necessary to move forward with something of this nature, it should be fully transparent and have proper legislative oversight to ensure that it's done in the best interest of the people of the state of Illinois. This plan, bless you. This plan needs to be halted, and it warrants more scrutiny. I'm here to ask you, the members of the General Assembly, to join me in asking the governor to scrap this rushed plan and focus on the most important job at hand, which is passing a budget. With passage of a budget, you, the General Assembly, will regain your authority and your power to have oversight of initiatives like this. Thank you again for having me here today, and I'd be happy to answer any questions that you might have.
Thank you, Comptroller. Just a couple questions about how the money is flowing right now, which I think all of us sometimes struggle with. So right now, what is our bill backlog as of today?
Our bill backlog as of today is about $12.3 billion. And this is a pretty good chart that shows you kind of what our, whoops, it was upside down. So let me, unfortunately, fix it. Yes. So this dates back to 2010, and it kind of shows you the up and down nature of where our budget deficit is going, our backlog of bills. Since 2014, this is the trend that we're seeing. We are now, on this particular chart, which is already outdated, this is at $12.1 billion. Last month, as you know, we were at 13, we exceeded 13 billion. We had a really good revenue month, the only good revenue month that we'll have, which was April because of tax season. And we were able to make about $950 million in payments to hospitals and MCOs. This was a priority, but that only accounts for about 30% of the payments that they're owed. So this number, the only certainty, I talk about the fiscal instability in this state, the only stable number that I can give you or certainty that I can give you right now is that this number is going to continue to go up. It's the only safe bet.
By the end
we have a budget.
By the end of this fiscal year, where do you think it will be at
We will be at $17 billion is our best estimate by the end of this.
At the end of the fiscal year.
Oh, I'm sorry. By the end of the fiscal year, we'll be at 14, and by the end of the calendar year, we'll be at 17 billion. And if we don't have a budget in place by June 30th of next year, we're looking at around $24 billion in bills that have yet to be paid. And this is absolutely unsustainable. Things will be closing down. It's very realistic to even talk about universities closing down entirely. We just can't pay the bills when we don't have the money in the coffers.
So there are in place, as we all know, a series of court orders that are mandating payments and certain expedited payments for some Medicaid, for all Medicaid payments under the Beeks and Memesovsky consent decree. There are also, as I understand it, some federal regulations that require timely payment of fee-for-service, or timely, let me ask the question, let me stop and ask the question again. There are federal regulations that require timely payment within 30 days for hospitals, doctors, dentists, and certain other medical providers. Is that both for providers that are paid by MCOs, or is it just for those who are fee-for-service, or is it both who fall in that category?
If I may, Kevin Shobin, Assistant Comptroller. So what you speak to in terms of the priorities for the consent decrees, those are a priority in the office, and then they're one of the 5 priorities when you include debt service, general state aid payments, state payrolls, and pension payments. Certainly the Medicaid is certainly not only in line pursuant to the court order, but they're paid on a regular basis each month. And that's about $180 million, and that does include all of those that you had expressed, the residential for adults, for both DD and mental health.
Those were not on my list. So are you saying they're different?
No, related to the consent decree, of the $160 million we pay, pursuant to the Tate, the Beeks, the Ligas, and the Williams, those court orders are all the priority, as well as the doctors and the optometrists and the dentists. We also make that a priority because of the federal requirement that they have to get paid within 30 days.
So that would be whether they are within a managed care system or if they were in a fee-for-service system.
No. So then managed care is separate. So managed care is outside of those priorities that I just mentioned, and those are priorities when we're able to get to those payments, as the Comptroller mentioned in April, when we had income tax come in April, we were able to leverage 400 in federal money, leverage 400 GRF, 400 federal, to issue $800 million. That was, and the previous bulk payment to MCOs was $100 million at the end of March and $100 million at the end of December. So that was outside of.
Okay, so let me just see if I've got all this correct, 'cause this is complicated. So you're saying that doctors, dentists, hospitals, providers of that ilk, if they are within let me ask the question before you answer it. Yeah, if they are within the MCO, they get paid when the MCO gets paid. But if they happen to be doctors, dentists, and others who provide services to Medicaid patients through the fee-for-service part of the program, they get paid in a 30-day window because of federal requirements.
Yes, but to add more complexity to that, that's GRF only. So the department is here and they can answer. Well, what they'll do then is from the other non-GRF funds, the healthcare provider funds, and they have a couple other funds that they use to make sure that payments to MCOs can be made that can meet within the 30 days to the podiatrists, the optometrists, the dentists, and the doctors.
And this may be a question for Director Norwood when she comes up, so I'll just ask it, and if you don't know, we'll ask it when she comes up. So are doctors, dentists, orthopedists, all those people we're talking about who happen to be operating in the Medicaid system under the auspice of an MCO. So they're a doctor serving, they're a member of an MCO, and they're seeing a client through Humana or Aetna or whoever that is. Are they subject to the same federal payment requirements for the 30-day reimbursement that we are as a state, or do those not exist if they are a private contractor?
It is my understanding that they are, and I would have to defer to HFS for clarity on that. they deal with that on a
I mean,
daily
I think that's a
I
big
think so.
question. Yeah, a big question. Okay. So I think it's important that we, because all of us in our offices, we are constantly getting barraged by calls from providers of all sorts, whether it's your nursing home, your pharmacy, local doctors, dentists, saying that they are, X number of weeks, X number of months behind. So if there is some language that could compel them payment, I'd like to really understand what that is and who it applies to. So, we'll follow up with the director on that because that's probably more in her bailiwick. But let's get back into something that's more specifically related to the payment of all these bills. So we know that there are court-ordered payments going through your office, as you described. I also understand that there have been 2 recent legal filings by persons who claim they are not, or entities that claim they are not being paid in a timely enough fashion, and the state is actually not in compliance with those consent decrees. Could you sort of describe what that legal action is and how soon it's coming and what the potential outcome could be for us?
Is this related to the MCOs in particular? So there's a court case right now that's pending. The Attorney General is representing the state on that. We're in communications with the Attorney General. I believe that they've asked for it's an agreed-upon extension of time to make the case.
So what's the nature of the case?
That they're not being paid on time, even given the court order. What I can say is that if the court sides with the plaintiffs on this, in other words, the MCOs having to be prioritized or moved to the front of the line on payments, then my position is going to have to, unfortunately, be that I'll have to go to the courts and ask them, okay, we'll do that, but which order am I going to be given authority to violate? Because we just will not have enough money to make other court-mandated payments. That's how low we are in funds. To give you an example, yesterday, we had a balance of $159 million liquid, and today we had to make a payment for $168 million in that ballpark. So we had less money available for the next day's payment than what we actually had in our balance. So you can imagine if the courts come back and say you have to pay the MCOs before anyone else, and we're talking about hundreds of millions of dollars, actually billions of dollars, we owe them $2 billion, I believe, that's going to mean that other folks are not going to get paid because even if we wanted to, we just can't do it. So it really will come to a point where our office will have to go sit down with the courts and say, you've given us all these things that we have to pay, but there physically is no money there to pay it with. Who do we not pay? It's the worst possible situation to be in, and that's the situation our office is really in because we just don't have any budget authority. Or I should say no spending authority, no appropriation authority.
So when do you expect a decision to be reached in this?
Well, I mean, I don't set the timeline for that, but it's being discussed now, so I would assume, soon. And we're preparing for the worst. I think everybody here should be very cognizant of the fact that this is being, it's going before the courts any minute, and if this comes down, there will be a situation where the Comptroller's office has to say, who do we not pay? Because we just don't have the money, and we're going to be, whether we want to or not, in violation of probably multiple court orders. So please.
Are there other questions from other members? First, let's add Representative Feigenholtz to the roll, and then Leader Belloc.
Thank you very much. And I certainly respect the Comptroller in your comments, going over your letter to Governor Rauner, which seems to be one of the major things here today. You brought up a lot of points. I'd just like to go back over what I think is the major reason why this is happening now. And, going over the last probably 7 years in trying to help the Medicaid system from imploding in the state of Illinois. There were major changes, not only in the rest of the United States, but in Illinois, probably the most major changes of health care, starting with the reform of the Medicaid system in the SMART Act. Then we went into the bill, and that was bipartisan, fully bipartisan working on that. Then it was bipartisan working on the managed care. A lot of people had problems with that issue, but at the time, time, they made it seem like we were the first to do managed care. I want to tell you that 87% of the rest of the United States is already in managed care, so we were one of the last states to leave the train station on managed care. So then we did the managed care, then the Affordable Care Act happened in the feds, and then that affected us also. Then we had the expansion of Medicaid, so we took in another 652,000 people, in the expanded care. Then we had a change in administration and then a change in party, so everything changed there too. So it's all been change. So, but I think that we have an excellent head of HFS and DHS working with that. And managed care throughout the rest of the United States, especially throughout the Midwest around us, when they were at 50 to 70%, we were only at 7%. So we got into it under Secretary Hamos, of which we had almost, when we went through it, and again, it was brand new for us, but we had over 30 ACs, CCOs, whatever they were, 30 managed care companies. Then we reduced it down to 12. Okay, in studying the rest of the United States, the majority of states that have been successful, and this is the issue that I have with you in, yes, most of the time I agree with, more competitive, but in most of the other states that they have been successful, they have reduced their numbers of managed care companies in order to address the issues of which we, especially the people on this committee, face every day with the providers on one side and the managed care companies on the other, dealing with the issues of which we had the open hearing talking about this, and the director of HFS sat through all those. We went through credentialing with providers, how important that was. We went through denial of claims. We went through billing codes, all of those issues which most people think in a smaller amount, 5 to 7 managed care companies would be easier to deal with because everybody was having to go back to 12 different managed care companies all the time. I think the MCO organization would say the same thing on that. So on that issue, I think that what the governor and the HFS is trying to do is simplify the system to help us get our Medicaid program not to go backwards but forwards and a better fiscal footing by doing so. I don't see how keeping it the way it is now, because we have worked so hard to do this in the state of Illinois, I don't want to take the chance that all of a sudden everybody's going to want to leave Illinois because we haven't corrected the system. And the system itself, outside of other issues that you have, I would address that issue with you, that I think that that is the right thing to do. I think the governor and HFS is on the right track in that respect, because as sitting as minority chair and with the majority chair, we've been in the middle on this between the providers and the MCOs, and it wasn't working out. And so I think that that is a key issue here in trying to get the system in a better place so we can get a better fiscal footing so we can pay those bills, because the whole issue in working with the Medicaid system was to provide better health care, access to care, quality care, a medical home, and provide the people the most, needs the people in Illinois that need health care the most to have a primary care physician. And that is the object of this system, and I think that that is what, in my own opinion, and that's why I support the governor and HFS and the director and DHS in working together on this, in trying to improve the system of Medicaid and the financial system itself in order to be able to pay our bills. Nobody wants to have $13 billion of outstanding bills. Nobody. And so if we let it go the way it is now, we're going to be at $17 billion like what you said, but it's going to be much worse as far as the people, the actual people that we want to provide those services for, because we get calls all the time. I had to call somebody the other day of one of the managed care and HFS of somebody that had a brain tumor, and they, there was a mix-up in whatever was going on, and that is some of those issues that I just mentioned, the credentialing, the billing codes, the denials. If you sat through that other hearing, I had 15 pages of notes written down of the problems, so we need to solve that. And that's where I think that that one key issue here is something that the administration is addressing, and that I hope that they will be successful at.
Well, first of all, just to be on the record, I was supportive of the MCO plan when we voted on that when I was still in the legislature. So for me, this is an issue of like pro-MCO or anti-MCO. It's truly an issue of accountability and transparency, Representative. I do not believe that we should have more oversight on purchases of paper clips than we should on the largest procurement in the state's history, which is related directly to the largest spending item in our entire budget, which is health care. So this is an issue that should concern every member of the General Assembly, because the oversight of the spending of the appropriation authority should belong to you and not to the administration. This shouldn't be something that they have full authority over, and you really have no, let's say you hated what's happening right now, and I would agree that there's probably some folks who support it and there's other folks who don't. But let's say that an overwhelming majority of you did not support this and you thought that there should be greater oversight and transparency here. You have no say. As members of the General Assembly responsible for appropriating the money that would go towards these expenditures, the largest budget expenditure for the state of Illinois, you've given over the entire authority of that, your authority, your power, and I was in your seat before, to the executive branch. As a member of the executive branch, I would say you shouldn't do that. You should not do that. The Illinois General Assembly should take its power back in determining how the largest expenditure in this state's budget is going to play out. And if truly every single person who has a voice or should have a voice in how this money is spent had the ability to have an influence, to actually vote on something of this nature, I think that's the appropriate way to do it, through an independent procurement process and not like a loophole, which I don't think was right when Governor Quinn did. As a Democrat, I will say that. It wasn't right when he did it. It caused a ton of confusion. It was, I would say, not the smoothest rollout of this plan. And all we're doing is doubling down on what was already a bad policy rollout to begin with. So again, just to be clear, I'm not here to advocate against MCOs. I want the most efficient and effective system of healthcare for the people of Illinois, whether they live, like I said, in Marion, Illinois, or in Chicago. But all of you as members of the General Assembly should frankly take back your authority to determine how you appropriate the funds and where they get spent and when they get spent and if they should get spent. That's your job, not his job. And truly, I just believe that I could not sleep at night if I did not reiterate how important it is to shine greater light on the largest procurement in the state's history, which is going to impact millions of the most vulnerable people in the state of Illinois, who are not just my constituents, they're all of yours. Yeah, and furthermore, well, okay, I'll leave it at that. Yeah, I mean, this authority, the only way you get it back is with the passage of a budget. And again, I would love to be able to do my job better. The only way I can do that is if I actually have money there to spend. And again, I'm not asking for new spending authority. I'm just asking for an appropriation that will allow me to pay for $13 billion worth of overdue bills for services that have already been rendered. Right? This is just, it's an insane situation which is untenable moving forward. It's unsustainable.
Well, I guess just as to follow up
So the $17 billion, Representative, it's not the MCO. This is because we don't have a budget.
Oh, yeah. No,
so
I know
that number is going to continue to go up to 24 if we don't have a budget. So, but to deal with something of this magnitude, a shift in policy that's this large, that has such an impact on the budget, and to do it basically under the cloak of darkness when we haven't been able to pass a budget in broad daylight, is probably not the soundest policy time to do it. Not right now. It's not the right time.
I wouldn't call it the cloak of darkness because we've had a couple of hearings on this already with the director. And so we had a lot of concerns. We talked about them with her. I mean, that was about 3 or 4 months ago. And so,
and as Representative Harris mentioned, when questions were asked of the administration in response to that initial hearing, not a single one of them were answered, right? And this is a problem. When members of the General Assembly ask questions, or if I ask questions, I shouldn't be directed to a website, and neither should you. The administration has a responsibility to answer the questions in the same way that I have a responsibility to answer whatever questions you guys throw my way, whether I want to or not, right? This is part of the deliberative process, and we owe it to taxpayers to shine a light on what we're doing here.
I felt that in that hearing that the administration or the director of HFS was responsive to us in the questions that we asked that day, of which they could answer to us that weren't involved in the actual
I respect that. And just to be clear, the letter was not to the director, who I have a lot of respect for. It was to the chief person in this state, and I think he deserves to respond to the questions that he asked, which are not political in nature. They're strictly about policy and how we intend to pay for things that impact people in this state. It's a fair question. It should be answered. Thank you.
Thank you.
So we have add Representative Ford to the roll. We have Representative Andrade next for a question, then Representative Demmer. Oh, and add Willis to the roll. Mr. Andrade passes, Mr. Demmer, and then Ms. Gable.
Thank you, Mr. Chair. Welcome, Comptroller.
Thank you.
I want to ask, I was surprised to see a letter from the Comptroller's office come out, and I want to ask, and what is a RFP between the Department of Healthcare and Family Services and Medicaid MCO providers? It was interesting to see the Comptroller's office get involved in that. And so one question would be, are you aware of, in other states, when these have happened, as Representative Belloc pointed out, Medicaid MCO contracts are commonplace across the United States. Are you aware of a comptroller intervening in an RFP process and testifying in other states?
I'm not, but it doesn't mean it hasn't happened. But what I would say is I'm not really concerned with what other controllers are doing in other states. I'm concerned about what my job is, and I'm the state's chief fiscal and accountability officer. And so I believe that. Here's what I will tell you. I'm not aware of any other state that's gone 2 years without a budget. So it's, uncharted territory. And, this is not your grandmother's controller's office.
I agree that the comptroller being involved in an RFP is uncharted territory. I'm curious, you admitted, and rightfully so, that you voted in favor of the bill in 2011 that established the first set of goals for the state to enroll individuals in Medicaid MCO programs. At that time, did you consult with the comptroller's office about the advisability of that program?
Again, at that time, the legislature did their job of having oversight on what we were voting on. It seems that people have abdicated that responsibility or maybe weren't even aware that this was happening.
So as a legislator, you didn't need the input of the comptroller's office, but now you believe that we as legislators need the input of the comptroller's office.
Well, at that time, we hadn't gone 23 months without a budget, so times were different back then.
Do you think that this committee should invite the treasurer or the secretary of state in to talk about the healthcare RFP that's offered by HFS?
Sure, why not? I think anybody who represents anybody in the state of Illinois should have a voice. And if, I'm going to exercise my voice as often as I can if I think it's in the best interest of the people of this state. And I'd encourage anybody who has an opinion on this to voice it. That's what hearings are all about.
We've had many hearings in this committee about this specific process. I know many of the members of this committee have had individual meetings with folks from the department to answer questions, to walk through what the timeline looks like, and we've been doing this for several months. Were you aware that previous hearings were going on, and if so, why didn't you use that voice in those other committees?
I'm here today, and I have spoken with different members of the General Assembly, including the chairman here, about this very issue, but most importantly, I've tried to be responsive to the many people who have voiced their concern to me as the state's chief fiscal and accountability officer. So yes, I'm here in my official capacity talking about how rushing through a program or a procurement with very little to no oversight is going to have a massive financial impact on the state of Illinois. So absolutely.
Not rushing through as much for folks who have been through these hearings for months.
Yeah, well,
it doesn't feel as rushed if you don't wait until 2 weeks before the RFP applications are due.
Fair enough that we have a disagreement of opinion on what we would consider rushing through. I think when we have more oversight on how we purchase paper clips and how we support the largest procurement in the state's history, I would consider rushing that through. So all I'm asking is, hey, let's put a pause on this and let everyone who wants to ask questions ask them. And I believe that there's still a lot of your colleagues who may not even be aware that this is happening. And I'm here today to voice why I believe that this is being rushed through. We can agree to disagree. But I think that, my voice is not just mine today. I'm speaking on behalf of many people in this state. And as I mentioned, 3.1 million people who represent the most vulnerable people in our healthcare system who can't afford to hire lobbyists or maybe even talk directly to their state reps or senators to get them to fight on their behalf. But I'm happy to do that for them.
So, the timing of this seems very rushed to wait until, a week or two before the application deadline. But I'd also say that I think there's a lot of discussion about the political aspect of the letter that was issued and of the comments that have been made in relation to it. What I would be, and I'm not the only one who thinks that. I mean, you can look at headlines that say, you know, Mendoza blasts Rauner over whatever. There's many
I don't
of
write
those
the
out
headlines,
there.
as you
I
know,
understand,
right?
but
So-
you know, it reflects that many people looked at this and saw a political angle to it. Many
That's
people in the press
unfortunate.
saw a
Yeah.
political angle to it.
Did you read the
It was
letter,
also
Representative?
very-
I'm just curious. Did you read the letter? Because
Yes.
if you
Oh,
read the
it's right
letter,
here in
and
front of me.
I'm happy to share it with
It's
the
right here in
entire
front of me.
universe,
And
it is
so
the most non-political letter on earth. It is strictly, it's respectful in tone, and it strictly deals specifically with this issue and what my concern as the state's chief fiscal officer is. And it asks the governor to have a dialogue with me about this. So if he
Very
doesn't want to
shortly-
answer your questions and doesn't want to respond to my request for a dialogue, that's on him. It's
Very
not on me.
shortly after this letter was offered to the public in a, you know, public format with a lot of comments that went along with it in the press, a group of Democratic senators held a press conference and were very political. They had signs that were printed up that said, "This is a Trump Rauner, a secret plan to destroy Medicaid, secret plan to destroy Medicaid." Now, this was, you know, in the hours following the issuance of your letter. So my question to you is, did you coordinate with those Democratic
Not at
senators
all.
before this?
Not at all.
So
I
they
can
have
give you my word
they
on
have
that.
somebody who can print them up a sign overnight and
Well, you
get it
should
ready
ask
to
them
go
that
in the
question.
blue room.
I'm
Your
happy
office
to
had
have
no
you ask them that
communication with the
question.
Senate
No
Democratic
communication from
Caucus
me
or
to
any
them.
members
Not at all.
before this
Not
letter
at
was
all.
issued. It's that
I
gives
think
that
those
was
senators are hearing clearly from the same people that I'm hearing from about their concerns about this system. So no, there's no collusion. As much as there's like a massive tinfoil hat conspiracy theory, I think with lots of people in this
This
dome,
illustrates again
I
that,
had
again,
nothing to do with that.
people
But
were-
I'm glad that they
people
did.
were very political in talking about the letter that you issued only hours after you issued it, and so I think it rightfully so attracted some scrutiny.
Sure.
You've talked a little bit about the timing of this, and I would refer to the FAQ that was issued by the department talking about this RFP. So this was sent out a couple months ago. You know, tried to walk through a lot of the different aspects of it. One of the items talks about the timing and says that in April of 2016, federal CMS, Centers for Medicare and Medicaid Services, issued new rules and regulations. That some of those rules and regulations go into effect on January 1st of 2018, some on January 1st of 2019. The RFP that's currently before us has an effective date of January 1st of 2018. Would you suggest that we delay and not comply with those federal CMS regulations?
Sorry, what was your question?
Would you suggest that we not comply with those federal CMS regulations?
No, I'm not suggesting that we don't comply with regulations. What I'm suggesting is that we don't have a budget, and we're trying to pass through the largest size procurement in the state's history at a time when the national healthcare scene is in complete shambles as well. We don't even know, like, let's be honest about this. The people who are even going to bid on this RFP, if you get bidders, they're not even going to be able to put forth legitimate bids because they don't even know how many Medicaid people are going to be in the system because we don't know what's going to happen in Washington yet. So this is not an issue of like, should we have MCOs or not? Is it even a good idea to reduce the size of MCOs? You know, this is not why I'm here. I'm here to say that there's no legitimate reason why we should rush through the largest procurement in the state's history with very little to no oversight. I'm pleased to hear that you've been intimately involved in this project,
As I think
but a
all
lot of
members
your
of this
own
committee have
colleagues
been.
have not.
I think all members of
And a
this
lot
committee
of,
have
most
been. We've
importantly,
had
a lot of
many
people,
hearings.
excuse me, a lot of people out of this chamber, the people that are most impacted by it, because I don't believe you're on Medicaid, those people.
And
Those people are who I'm here to speak for today.
We have providers today who are testifying, and they have to wait through this. We have to hear from the healthcare experts and the providers who are directly affected today.
I agree.
And they're waiting through
I'm looking
this.
forward to hearing about today's testimonies.
So
I don't believe I'll be the
I'd
only
like to
person
ask a
with
little
this
bit
opinion.
about, you know, the financial aspect is one piece of this, but there's also a very important quality and provider engagement aspect to the RFP process. How would you describe the quality of care that's being provided in the state's Medicaid program today?
I'm not here to talk about the quality of care. I'm here to talk about the fact that we are trying to ram through the largest procurement in the state's history, which will have an impact on our budget at a time when we don't even have a budget. So this is what I'm here to talk about. I think there's going to be lots of people behind me who are going to be here to testify about how they believe that's going to impact quality of care. Maybe some will say it'll improve it. Maybe some will say it won't. That's not why I'm here today. I'm
Well,
here
I think
to
that's the
specifically talk
conversation we
about.
should be having, is what kind of quality care we're delivering to the most vulnerable residents of the state of Illinois. That should be the front and center motivating decision behind this initiative. And I'll give you an example of this. One of the issues that's been cited is that it's very difficult for providers to work with many, more than a dozen different Medicaid MCO providers. They have to go through different process with each one of them. They have to, all this administrative, this overhead work. We had a committee on mental health hearing a couple weeks ago. There's a gentleman there from a group who provides mental health services in Iowa. One of the things he volunteered, we weren't even talking about the RFP, one of the things he volunteered is that it's so much easier for providers in Iowa to be able to work with the 4 or 5 MCOs that they have in Iowa. They don't have to waste time dealing with administrative bloat. They can focus on providing care to the patients. They can focus on providing what their mission is, and that's providing quality health care. And I think that's an important aspect that we have to talk about today, that the financial concern is certainly one that we all have to keep an eye on, but our motivating decision should be about quality of care, about having adequate number of providers, and making sure those providers don't have to jump through too many hoops to be able to provide that care to people today. So I'm troubled when I see some of the comments you talked about with, well, let's just get more MCOs out there because then we'll have all this choice between them.
I did not say that.
That will increase the amount of administrative overhead and the dollars that we have to spend on office work instead of spending those dollars on providing care directly to individuals. So I appreciate the answers and the responses we've gotten here, but I think it's important that we talk to healthcare experts, we talk to providers, we talk to community advocates during this process, and that we avoid, whenever we can, the kinds of political shows that come out of letters like this and press conferences and stand-up boards. Let's focus on the quality of care for the individuals. Thank you.
Yes, and I was just going to talk real quick.
So actually, let's continue to have questions from the members, please. Representative Gable, then Manley. And add Representative Flowers to the roll.
So, so you've talked a lot about the procurement code and the fact that this RFP was exempt from the procurement code. Do you think that that the employees working on the RFP should have consulted with the chief procurement officer?
I think there should be an independent procurement officer overseeing this process. I think the fact that when the prior administration rolled this out, there was so many problems and so much confusion, and we didn't learn from that experience, and instead are using the exact same loophole, which is this purchase of care option that avoids an independent procurement process. Instead of saying, well, let's fix that and not do that again, let's have lots of testimony about this, let's flesh this through, and most importantly, let's have some legislative oversight on this and not just give up all our power and authority on appropriating these funds to the governor's office. I think that that's the responsible way of moving forward, not doubling down on the mistakes of the past administration, but actually correcting and building upon that.
Mm-hmm. They've said that this managed care will put us on better financial footing. My sense is that we have no idea really what this RFP is, what kind of financial footing it's going to put us on. But I agree with you that the best way to put us on better financial footing is to have a budget.
That's right.
So thank you for coming in today.
I think this is a debate worth having, but I just don't see the need to rush it through. I want to be clear, I'm not here to talk about the policy aspect of MCOs. I'm on the record having voted for them. I think, though, that when it's an issue that impacts so many people across the state of Illinois, the most vulnerable to be precise, this deserves greater scrutiny. And you all, as members of the General Assembly, should have a greater voice in how we're spending this money.
So I think Representative Manley was next, and then Willis.
I was just talking to Representative Lilly about what happens in this room. So one time we were in this room and we got called sexist. All the women on this committee were called sexist by a member of the governor's administration, and now we're talking about how we don't like politically charged press. We live in an environment where that is commonplace. So it just blows my mind. Comptroller Mendoza, thank you for being here. Thank you for doing your job and trying to help with the situation. I appreciate it. I really do. Can you tell me in how heavily the weight of the uncertainty at the federal level, how do you feel about that? Just the sheer weight of the uncertainty and what it might mean for the state of Illinois.
We may potentially lose 170 to 175,000 people on the Medicaid rolls just in the first year. So what
happens to them?
They're not going to be eligible.
They're not going to get sick anymore, right? They won't need a doctor.
Of course. They're going to die.
Nothing bad's going to happen to them. Magically, they're going to be okay, right? Oh, wait, they're going to go back to the emergency room, aren't they?
That's exactly right.
And what is that going to cost us?
A lot more.
Okay.
And it, by the way, doesn't fix people's problems, because maybe emergency rooms can, by law, have to provide emergency services, right? You have a heart attack, they're going to stabilize you. But then every aftercare aspect of that is not going to be covered. You know, I mean, people, if they're not part of an insurance plan, the odds are they're not going to ever receive the quality of care that they need to stay alive and be healthy. And honest to God, if somebody from Southern Illinois has to drive 60 miles to go get their prescription because they've now been moved onto an MCO plan at such an unstable time in our state's fiscal history, you might as well just say that person doesn't have health insurance, because they're not going to drive 60 miles to go get their prescription when they could have gone to their local pharmacy to get it today. So I have a major concern about what's happening.
Last question from me. At the moment, the MCOs are engaged in legal action seeking payment from the state. Is it the appropriate time for making such a drastic change, in your opinion?
It's probably the worst possible time. We have so much uncertainty, not just fiscally here in Illinois, but also in the Illinois courts as to whether or not I'm even going to have to pay these MCOs before anyone else. Again, I said if I'm directed to pay the MCOs first, then I will have to go back to the courts and say, okay, now which court order am I going to be allowed to violate? Because there's no more money. It's such a huge chunk of the budget. It is the largest section of our budget. To have to prioritize these payments and have no wiggle room as a controller to triage this situation is going to be catastrophic for the state's finances. They're bad enough as it is. And on top of that, we owe $2 billion right now to the MCOs. This RFP, what's going to happen to the folks that aren't selected for the RFP that currently are MCO providers at a time when we haven't paid their bills? Are they just going to completely lose out on all of the money that they're owed? These are legitimate questions that have to be asked. They really do go to quality of life, not just for the patients, but also to the providers. It may put providers out of business, hospitals and safety networks out of business of helping people. So again, let's have this discussion, let's have this debate, let's talk about an RFP in the future, but not at the worst fiscal time in the state's history. And I would like Chase Reeswinkle, is that right? Ray Winkle, I'm sorry. He's our chief economist in the office to talk about the economic implications of this.
Well, you were talking about the ACA and what that implication might be on the state, and we have been discussing with a lot of the economic policy experts on the federal level, and some of our concern with that was they were projecting somewhere between a $7.6 and $8.4 billion hit to the Illinois economy as a result of passing that through the Senate. Obviously, you'd have to assume that they would, and somewhere between a 55,000 and 60,000 job loss. Now, that's obviously not all in the healthcare industry, although that is our third largest, combined with health support services, our third largest labor sector in the state. It also has trickled down to people that are unable to work as due to not having healthcare coverage and things like that nature. So that is a concern of ours going forward.
Thank you, Representative Willis.
Thank you, Mr. Chairman. Comptroller Mendoza, here I am back here. One of the things, I also happen to sit on State Administration Committee, and one of the things that with Chairman Riley, we're actually looking at procurement reform. Have you been asked to help with that? on many of the things that we're working through.
Wait, is this a question about a committee other than this? Because we're not
Oh,
having.
no, just about making sure that we're involved, and this is actually, I think it does link to this as we're talking about
With the procurement of
so-
care, we've been in
care.
discussions about potentially amending the procurement of care qualifications because it just doesn't seem, you know, that it makes any sense whatsoever that the largest procurement in the state's history can
Which is what
be
this
rushed
one
through
is,
through a
right.
procurement of care loophole. So there should be some sort of financial, you know, cap to what could be considered a procurement of care. But that'll be up to you to decide. I mean, a purchase of care. That will be up to the General Assembly to decide. I do think, though, when we were approached about that with that question, that clearly that makes sense.
It makes all the sense in the world. And then as we're looking through the landscape of the MCOs right now, it's actually very fragile when we're looking at making sure that we have access to care. And I think that's something that we're looking at. And you actually just answered one of the questions that I was going to present towards you. What happens if this RFP goes through to those MCOs that aren't successful and the outstanding money that we're looking to them?
Well, I mean, there are going to be winners and losers. That's always the case. You know, my testimony today isn't about picking winners and losers. The question, though, clearly, those folks who don't qualify for the RFP, my biggest concern of what happens to them is what happens to the money that they're owed, because there's no contractual clause that guarantees that they'll be paid for the money, for the services that have already been rendered. So this could potentially be devastating, for example, to the safety net hospitals that are part of one of those MCOs. They rely on those dollars for part of their operation, so, I mean, it's possible that would probably put 500 people out of work. But it's not just going to be them, it's anybody who applies. And this is the nature of, you know, there's going to be folks who get accepted and folks who don't. I get that. My point is, it's already fragile enough right now. We don't have a budget. This impacts our budget, whether we'd like it to or not. It is not the right time, given the state's fiscal instability and the national health care instability seen right now, to be rushing this through.
And then the final thing is mostly on the safety net hospitals. If they're barely surviving now as it is, and they're in communities that need them the most.
African-American and Hispanic people are going to be impacted tremendously if those safety net hospitals
and if they go down,
negatively
access to
impacted.
care is going to
That's
go
right.
down even more. So, thank you very much, ma'am.
And Leader Bellick, did you have a follow-up question?
Thank you very much. And again, Comptroller, I respect your opinions. I'm just going to go back to what Representative Demmer said also, is that the key issue is here is to serve the Medicaid population in the best way we can, with good access, good quality care, and a medical home. So when we started on this thing of trying to keep the system from imploding when Governor Quinn, was on that, and the bond houses said, you don't have to face just pension reform, you have to face Medicaid reform because your system's going under. So that was when we started all these issues. Our prediction at that time, or the administration's prediction, that administration, was that this could go from $7 billion to spending $17 billion on Medicaid. That is now $22 billion. We've gone from $7 billion to $22 billion spending on Medicaid. And so that was where the managed care came in, because it wasn't working still. And so the managed care was supposed to help that. So I'm just staying on that issue because the competition and everything that's involved in this, I think that is the goal of the administration. They are trying to save this Medicaid system in Illinois and address the people that are the most vulnerable. And in order to do that, again, I respect your job as the comptroller, but you were over there. We're the ones that are getting the calls. I mean, really?
Oh, I get them all the time, trust me. Yes.
Okay, because all I got for the last 6 months was calls from the MCOs, calls from the providers, calls from the individuals. Everybody had a problem. So this issue of moving forward is to try to save that system that we have spent the last 5 years trying to save in Illinois and trying to serve the Medicaid population. So by doing this, if this doesn't help it, I can't count on what's going to happen in the federal government. I mean, at the first repeal and replace, they talked about freezing us at the 90%, okay? I don't know what that's going to happen when it goes over the Senate. That could be 2 or 3 years, and who knows if it's going to be anything. But in that time period, how are we going to save what we have going here, and I think that that is the administration's goal, is to move forward and try to save what we have done moving forward and make it better. And so that, and addressing the other issue with the MCOs, as the director said before, because that question was asked over and over in the last thing. They have contracts. They're private companies. They have to live up to their contracts, when you address the issue about the contracts. So I'm just trying to make that point again, is that there is nobody here that doesn't want to be successful with what we're doing in our Medicaid population. But moving forward, I don't think that this system, the way it is today, can exist, because we have, as I mentioned those problems before, you have the problems with the credentialing, the denial of the claims, the billing codes. There was at least, I took 14 pages of notes in that last hearing that we had, and we went over them. We went over a lot of the problems, with the administration, calling them, saying, this needs to be done, this needs to be, what's being done in that area. But I really believe that in order to save this system, it has to have a major change.
Yeah, I would say the number one way to help all of these providers is to pay them. We need a budget. So any reform that we want to talk about should come after you have a budget in place. And this RFP is due on May 15th. Again, there's no need to rush this through before you even have a budget in place. So all of the phone calls that every single one of us gets, because I have to believe that every legislator, whether you're a Democrat or a Republican or in the House or in the Senate, your phones are ringing off the hook. Clearly, the Comptroller's office sees it. We're constantly, literally trying to keep people alive in this state. This is how it is, Representative. For me, it's very personal. So having said that, if we want to fix it, rather than try to ram through the largest procurement in our state's history, let's pass a budget first. And then you're going to have phone calls that are actually saying, okay, well, we can revisit what's the best way to do this. But the best way to help any one of these providers and the best way to help patients is to actually pay the state's bills. Because then I wouldn't have state employees who are paying fully into their premiums being denied medical coverage by their doctors. Even though they have full health insurance, they might as well not have health insurance. Why? Because the state doesn't pay its bills on time. And it's not because I don't want to, it's because there's no money to do it. So we can talk about all the wonderful reforms you want in the world. They mean nothing when there's no budget. So you want to fix this? Pass a budget. And then hopefully I'll be the biggest cheerleader to reform this process. But in the meantime, there's nothing to cheer about because we have no budget in place. So every single person in this room who deals with healthcare has been impacted much worse than by any billing code, by the fact that even if they bill and even if they have the most perfect code, there's no money attached to that. Let's fix that first before we take on the biggest procurement in the state's history and ram it through without your oversight. And I think we could probably leave it at that. So if anybody has any additional questions.
So we will go next to Representative Feigenholz,
Okay,
and then the final
yes.
question is to Representative Fine.
Thank you, Comptroller, for being here and for your passion for this issue and concern about the consumers. Because I, as you know, like every other member of this committee and every member of the General Assembly, we've all been hearing from providers, from our constituents who have been turned away as doors to health care slowly close in this state, even for us.
That's right.
You know, our health care, our insurance cards are meaningless. I mean, we're not paying our bills. No one is taking anything, and I applaud you for encouraging this body to pass a full budget. I also want to underscore what I believe Representative Willis was trying to say about winners and losers. Nobody in this room wants to demonize managed care, and I think Representative Belloc made some historical points about people on this committee who worked together to try and manage a growing population of Medicaid recipients into a more cost-efficient system, which, as you stated, Comptroller Mendoza, there was constant change, constant flux, new administration, Hamos leaves, Norwood shows up, managed care, the whole punch list for managed care was left on the doorstep of a new administration. And although there may be discussion in the future about the merit of shrinking the pool of managed care entities in the state. The fact remains is that it is the largest procurement in the history of the state. We don't know what's going on in Washington. We don't really know a number of what is our managed care, what is our Medicaid number for people in managed care, what is the dollar value of that, and as Representative Belloc said earlier, what about those small issues? What makes us believe that they're ever really going to be fixed? Because they haven't been fixed. They are still huge problems. So I feel like things are constantly moving. It is governance by chaos, and we really need to slow things down and pass a budget before we move forward on what is the largest procurement and the largest change. I worry about no matter who's still standing, if the MCOs that win this bid can even absorb all of these people, given the fact that we're not paying them. So I'm totally appreciative of what you're doing and standing up for us and showing up here, because it's important to show up. Thanks, Susanna.
Representative Fine.
Thank you. I just want to wrap my head around everything as we're closing here. So I feel what I'm getting from the testimony is right now we're putting the cart before the horse, and we need to solve things in the state and get a budget before we can move forward. Because the issue right now is how are we going to pay our current bills, and if we change and MCOs, the new MCOs get put in the front of the line, are our current providers going to continue to be creditors for the state? Is that correct?
That's correct. Yeah, thank you. Thumbs it up.
Okay, so let me just wrap up by thanking you, Comptroller, for taking the time to come. And, to a point a friend of mine from the other side made earlier, I think we're always glad when we're talking about matters of fiscal importance to have the Comptroller show up. When we are talking about matters of the laws it affects to Illinois, we're happy to have the Attorney General show up. When we talk about matters relating to local government and consolidation, we are happy to have the Lieutenant Governor show up and address us. So we are always happy when an issue is of such importance that the constitutional officers of the state of Illinois take an interest in it. And from the money point of view, the thing that struck me was, we have litigation out there. I think there will be litigation more to come.
Yep.
I just cannot imagine there will not be. And any one of these is going to be the card that when it's pulled out collapses the whole house. And each of us on this committee as members need to really think about, what we do the day that happens and what we do the day after that happens. So thank you very much for coming. But let me just point out one other thing too, as a lot of us know that MCOs have value. We know that some of the problems deal with standardizing claims forms and credentialing forms and things like that, and those are sort of soluble, but whether you have easy credentialing or hard credentialing, whether you have easy claims processing or no claims processing, whether you have 12 MCOs or 5 MCOs, if you can't pay any of those people, that's a big problem. So thank you.
Thank you.
So next up to talk more about the non-financial side is the Director of the Department of Health Care and Family Services, Felicia Norwood, and Mr. Sean McGady, the Director of Legislative Affairs. And good morning, or good afternoon, Director.
Good afternoon. Chairperson Harris, Chairperson Gable, Leader Belloc, and honorable members of this committee, I'm pleased to appear before you again to discuss the state's RFP for managed care. Let me start out by saying to Chairman Harris that it's my understanding, and I have a copy in front of me of the letter that the governor responded to you on April 6th. So unless something happened in the mail, there was a letter that was sent on April 6th in response to the letter that you sent to the governor.
Maybe it ended up the same place as the letter to the ACLU. You remember that one that went astray?
I absolutely know the ACLU letter, but I can tell you the letter that the governor sent to you on April 6th was mailed by my office.
Okay.
So
do
we
you
have a copy of that, and we
'Cause
can make
never
sure
saw
that
it.
that
I'd be
is
happy
sent
to
to
see
you.
it.
The second thing I want to share is there was a lot of discussion today about the infamous loophole with respect to purchase of care. Well, the loophole must have been there now for over 20 years, because that is the way that the department has actually purchased managed care services in this state. So you have in front of you, which we can share, what this department has been doing at least since 1997. So I don't think I've considered anything with a 20-year history to be a loophole. Now, if the General Assembly makes the decision that the purchase of care process is not one that should be exempt from the procurement code, that's certainly something that this department and others will comply with. But I really feel strongly that to comment that the department is using a loophole to execute on something as significant as this RFP is just basically untrue. So we have included the language that lays out the authority by which we are executing on this RFP. It is the authority that has been in place for a long period of time in this state, and it is the authority by which we have purchased services for the Medicaid program since at least 1997. I can go back longer, but I thought a 20-year retrospective was probably appropriate.
Director, excuse me, I think you said you included this language. Is there a document that we don't have?
Sean Lewis has, I think, copies.
Okay.
For the committee. So that actually lays out the authority by which the department has rolled out this RFP process. And as I said, it is the authority that's been there for some period of time. With that said, I will say that we certainly appreciate the opportunity to appear before you so that we can answer any outstanding questions that we are able to, in view of the fact that we are in the middle of a competitive solicitation, and no one takes integrity, propriety, and doing things above board as much as we do at this department. So we will be happy to answer any questions you have within the confines of that. We have been going through this process with respect to this managed care RFP since February 27th. We have posted hundreds of responses to questions on the HFS website. We have conducted conferences for individuals that are interested in bidding on the RFP. We have posted all of that information to the website. So like the Comptroller, we take transparency very seriously. So anyone who wants to understand information that was shared, questions that were asked, answers that were given, and responses to the RFP has the ability to do that. We do that in that framework so that everybody hears the same thing. And no one can say that the department responded one way with respect to one question and another way with respect to another. So all of those responses, including any information that was shared in those meetings, is posted to the HFS website. We're in the process right now of waiting for proposals to be submitted to the department. As was mentioned earlier, those proposals are due to the department on May 15th, and at that time, we will continue the process of executing on this RFP. It's the largest RFP in the state of Illinois because the Medicaid budget is the largest budget in the state of Illinois. It represents resources that we spend today, not new resources, but existing resources, in an attempt for the department to deliver quality healthcare services to Medicaid beneficiaries with better outcomes in the most cost-effective way possible as stewards of the taxpayer dollars, which we all are. So that is what we're trying to achieve with respect to the RFP. The RFP states that we are looking for managed care organizations that are willing, able, and financially sound to support the state's Medicaid beneficiaries, and there are roughly 3.2 million that we have, and I will say, take very seriously our moral obligation to make sure that those beneficiaries have access to high-quality care. So we believe that this is a process that has transparency, it is a process that has integrity, and it is a process that has accountability and is being managed in accordance with the laws of the state of Illinois, which is how we do business. It has your oversight. We have come before you and the Senate. This would be our 6th appearance before the various committees with respect to the HFS, either budget, MCO oversight, or the RFP. So we are willing and certainly able to answer any questions that we can within this procurement and certainly within the process within which we operate. We took some time to go through the procurement code to see what this process looks like versus what things look like under the procurement code, even though purchase of care is actually exempt. And one of the things that we were able to see is that our processes mirror that in a very substantial way, and in many respects have gone beyond what that looks like. And we did consult with the Chief Procurement Officer, and I think everyone should understand that every department actually has a Chief Procurement Officer that is required to work collaboratively with the state's procurement officer to make sure that all of these things happen in a way that maintains the integrity of the process. So we have done that as a part of this. Throughout the course of this, I will say that we have received a lot of comments and feedback, much of which has been incredibly positive because this RFP was done, as we said earlier in our testimony when we first appeared before you, with the input of hundreds of stakeholders that we have met with over the past 2 years. And we have tried to take that input into consideration in putting together this RFP. There remains at this point several stakeholders who would still like for us to address certain things in the model contract. The ACLU represents one of those stakeholders, but there are others, the Kennedy Forum, various associations in terms of things that they would like us to address in the model contract. And what we have said is that we are going to get through this process, then sit down before we execute the contract. So we will use the time period once we pass the RFP to get all of that feedback, and we have brought it all together, and then be able to incorporate any concerns that stakeholders have that should legitimately be addressed in the model contract. And the contract is called the model contract for a reason. The state of Illinois is required to submit that contract to federal CMS for approval. So CMS ultimately will sign off on that contract. So while we make sure and firmly believe that any contract that we submit to CMS will be in accordance with all state and federal laws, they get that second look to make sure that the state hasn't missed anything. So we will continue to work with our stakeholders around issues in the model contract that we believe can strengthen that contract as we go forward. And that's the collaboration that this department has operated within during the time that we've been there. I don't think you will find one stakeholder that is asked to meet with this department or me, and we haven't been willing to do that. So we will continue to receive the input from stakeholders to make this model contract what it should be, to address the concerns that we may have missed, because we're the first to say, when we pulled all of this together, there may be some things in the model contract that we still need to work on, and we really want to do that. So we're going to continue to work through this process. We've had some comments that have come from the Child Care Association, comments that have come from the Kennedy Forum, comments that have come from the Association of Community Behavioral Health Organizations. So all of that feedback will be incorporated into the final contract that we use for the model contract. Our only interest is in making sure that we do everything we can to have a Medicaid program that achieves the promise of managed care, which is to be able to provide high-quality care to Medicaid beneficiaries in this state at a sustainable cost. With that, I will basically answer any questions that I'm able to do so.
Thank you, Director. And before we actually talk about questions and substantive matter, just thank you very much for your openness and willingness to come back here and keep talking to you about this issue. And I think you mentioned 6 times you've had to make journeys to the House and the Senate, and we appreciate you for doing that. But it also just shows how important it is, and I think to both Democrats and Republicans, that we get the Medicaid system right. I don't think there's anyone here who is doing this for any other reason, and we really have very deep concerns that this system run well. It's not only one of the biggest amounts of money we spend, but 1/4 of our people depend on it for their health care. And I think that underscores the importance. And thank you for providing a copy of this letter, which I had not seen before. And just looking at it and comparing it to the letter I wrote to the governor, there are a couple things that don't seem to be answered in the response you wrote. The first one being, who within your administration and agencies under your control insisted in the preparation of the RFP? And did any persons recuse themselves during the process?
And I think, Chairman Harris, this was a question that was asked before. So as I mentioned, the RFP was really developed by individuals from HFS and DCFS. The governor's office basically, as I mentioned, Greg Bassey is someone that we consulted on the governor's office side because he's the governor's human services special advisor. And we also worked in collaboration with Georgia Mann, who is the governor's counsel on compliance matters. So those are 2 individuals from the governor's office that collaborated with us, although I will say in terms of the rolling up the sleeves and actually doing the detailed work with respect to the RFP, that consisted of a team from HFS and DCFS.
So those were the only 2 persons in the governor's office who participated in the preparation of the RFP?
That is correct.
And did any...
As I said, I don't know if I would describe it as the preparation. We went to them for advice and counsel as we went through the RFP process.
But to that extent, I mean, there was participation from the governor's office, DCFS, and HFS. The next question, if I missed it, I'm sorry, did any persons assisting with preparation of the RFP have communications about the RFP with employees of any of the entities that attended the Round 1 offer or conference?
I can't answer that question, Mr. Chairman, because I have before me the number of entities that attended the Round 1 conference.
Or whatever and make that comparison, that would be of help.
And I will say, in that framework, the entities that attended the Round 1 conference would be entities that are potential offerors. Since we are continuing to operate a Medicaid program today, we certainly have communications with the managed care organizations that operate in the state of Illinois because they come to us with various questions in terms of what I would call the ordinary course of business. And we're also, at many junctures, trying to work with those same managed care organizations around things that might have to do with provider payments, for example.
But this question was specific to any communications in which those conference participants had communications with employees regarding the RFP.
As I said, I don't know who attended, but there were certainly very specific instructions that our general counsel sent at the onset of this process to both all HFS employees and all DCFS employees that there were to be no conversations as we went through this process with anyone outside of the team that was working on the RFP. But we can go back and check, but to the best of my To the best of my knowledge, the answer to that question would be no.
And then there were some questions that were less like legal and technical, but more to the heart of the provision of health care to the citizens of Illinois, that are continuity of care. What is the continuity of care plan? I'm just summarizing these. The network adequacy issue, if a provider suddenly is out of a managed care organization. Are there any changes to the delivery of mental health and substance abuse services? And then there was one. So let's start with those three. So continuity of care, network adequacy, mental health and substance abuse, and then especially within the light of the fact that managed care right now, as I understand it, it's only in 30 counties, and the statewide plan will be expanding this to 102 counties, if I remember my Illinois counties, 102 counties. So it's 72 counties where currently there's no network or provider system at all that's going to have to be created brand new starting in November and implemented by January 1, and how's all this going to work out?
So the way that the RFP is set up, each entity that bids on this contract is required as a part of that contract to submit in the RFP submission a list of entities that will be a part of their provider network. There is in the RFP process the ability to understand what that network looks like. So that information will not be coming in November. That information will actually be coming in May. So we will have visibility around the provider network as a part of the RFP process, and all of the managed care entities are required to submit that information as a part of the RFP process.
And will that be publicly available for people to look at and see, you know, how many doctors there are in Union County, how many, you know, dentists, where is the closest hospital, that kind of thing?
Before any selections or anything else of the sort will be made, Mr. Chairman, that will certainly be available for everyone to see and to try to understand what the provider network looks like. And, you know, one other issue that I think the Comptroller mentioned, which was something to the effect of people driving 60 miles or things of that sort. The network adequacy requirements are broad parameters. Illinois, though, like many other states, are what are called any willing provider states. So if you have a pharmacist down the street and that pharmacy is going to contract, that pharmacy has the ability to contract with every managed care entity that will be a part of this program.
But isn't that, you know, I've run into this problem on the private side also. Is the fly in that ointment, you know, certainly any willing provider if you're willing to accept the terms and rate offered by the insurer?
It's whether you accept, in this particular case with respect to the pharmacy, the terms and rates that are going to be offered by the Department of Health Care and Family Services. Because the reality is, one of the objections we heard from providers throughout this process was that there was no standardized formulary, so that you wouldn't have the ability to go to one provider and know what was in the formulary, you go to another managed care plan and something else was going to be in the formulary. So we decided to take the pharmacy issue off the table because it's an integral issue to health care for Medicaid beneficiaries. So that was one of the first things, in addition to credentialing, that we said that we were going to address. So I believe that another benefit of this process is being able to address this pharmacy issue in a very comprehensive way that, unlike where we are today, is very much in the best interest of Medicaid beneficiaries.
I think we're going to hear next from some pharmacists, and we'll see if they jump up and down and shake their heads and say,
well, the question of whether or
great.
not the state's Medicaid rates are what individuals want them to be, Mr. Chairman, it's another question.
Okay,
but
I mean,
I do think from where we sit, we tried to address the issue that many of them came to us on. So our objections and the things that are in this RFP responds to the issue of there wasn't a standardized formulary in the state. There were differences across that, so Medicaid beneficiaries didn't know as they went from one plan to the next. So those are the things that we addressed.
And I just think it will behoove all of us up here to, you know, look at these things, you know, because, you know, whatever systemic or bureaucratic obstacles there are to somebody, you know, getting their family the health care they need or the prescription they need in a timely fashion, average people on the street who are Medicaid recipients, they don't have the power to control or change those systems. They become, the victims of the bureaucracy when those things happen. So I think it's just incumbent on us to ask a lot of these questions and review this to be sure that there's adequacy in our neighborhoods and towns. So I don't want to take up all the time. I know that Representatives Gable and Ford had questions, and then Mussman. Okay. Well,
good afternoon. Thanks for coming to the committee again. I have a few questions around the cost analysis, and I'm not sure if that's something you can answer or not. But I know a lot of people say that we're going to MCOs to save money. And so I was wondering if you knew how much this RFP was estimated to cost the state annually, and how does it compare with the current total spending?
So the answer is, in terms of do we know what it's going to cost, the answer is yes. That is a part of the competitive RFP in terms of the technical proposal. So that's certainly something that I'm not prepared or able to share as a part of this hearing. But anyone who's bidding on this has been provided what is called the data book. The data book was provided by Milliman. It was done in order to make sure that we had actuarially sound rates, which is a requirement from the federal government. So all of the offerers that are bidding on that have that information. And certainly the expectation from the state's perspective is that we will see savings in this program from where we are today.
That is your expectation?
Absolutely.
And do you have fiscal analysis of that?
Yes, that's why we use Milliman. So, and that is the information that all of the managed care plans and offerers that are bidding on this have been provided.
And then on another note, do you know how many MCOs have stopped paying providers?
Well, I would say prior to last week, almost every MCO that we were meeting with continued to pay providers. There were some issues, to the best of my knowledge, with only one MCO that had stopped some of those payments. However, as you know, as the Comptroller referenced, the MCOs received roughly $800 million in payments soon after tax season was closed. Mm-hmm. So certainly our hope is now that that is no longer the case with respect to that one MCO and that everyone is paying providers.
Okay, but we're going to hear from, hopefully, them after this, because I've been hearing from them that they have not gotten paid, and they are not getting paid. That that the MCOs are not paying the providers. So,
and as I would say, to the best of my knowledge, the MCOs that we have met with, and I would say over the last month, that's been several, they continue to pay providers, with the exception of one that I was aware of.
And are you going to allow, so with that one, are you still going to allow MCOs that are not paying providers to bid on this?
The RFP process basically indicates that every managed care plan, either in Illinois or outside of Illinois, has the ability to submit a proposal by May 15th. We have not looked, obviously, at what's happening with respect to the one MCO, and it could be that once that one MCO received payment, as I said, they've started to pay providers. But the prerequisites for the RFP is that any entity that's fiscally sound and able to demonstrate that as a part of their financial proposal is able to submit a RFP as of May 15th.
Don't you think that part of that fiscal solvency, though, should be that they have to be able to show that they are paying?
I'm sure that is something that the entities or individuals that will be evaluating the RFPs will certainly look to, because you have to include information with respect to your finances as a part of the RFP process. So it certainly is going to be something that the evaluators will take into consideration.
Okay. I mean, I've heard that both FHN and Meridian are not paying. So that's one more than you.
Well, you can speak to Karen Brock, but I'm pretty sure that Meridian continues to pay providers, because we were aware of some primary care providers that they were trying to get help to. So I can't confirm that that is not happening, but I do know providers that they are paying.
I mean, you know, as we've stated here before, we all have concerns about what happens to the providers if they have if they're owed money by an MCO and that MCO does not receive a contract in the new RFP. So I hope that you've thought about that and that you have some process to make sure that they do get paid, no matter who gets the new contracts.
So, Chairperson Gable, we absolutely have thought about it. We will have a process in place to do our own audit of what's happening with respect to those MCOs. So our expectation is that we will go through a process of understanding what that looks like from the MCO perspective and from the provider perspective. I will tell you that often when you try to get agreement around what some of those numbers are, there are certainly variances, to say the least. But in terms of responding to your question, we absolutely have thought about it, and we'll have a process in place in terms of how we address that.
Right. And then just the last question is, have you designated any of the employees who worked on the development of the RFP or who will work on some scoring the responses as persons subject to the revolving door?
I will say that everyone who is involved in the evaluation of the RFP will comply with all state laws. Our Chief Procurement Officer provides individuals with a document that they have to sign indicating their understanding of what those laws are and their adherence to those. So yes, that process is being handled, and we are certainly very, very much cognizant of the fact that you will have individuals reviewing this and making sure that they comply with what the state rules are around these processes. So that will absolutely happen.
Okay. Thank you for your answers.
Sure.
Representative Ford, then Mussman.
Thank you, Chairman Harris, and good evening, Director Norwood. So I have a few questions about, I mean, just for my knowledge, are MCOs in every state?
I think we might be up to maybe 44 or 45 at this point, but don't hold me to that. So I can certainly get back to you on that, Representative.
And so how are the states doing without MCOs? What type of system?
They would have in place, Representative, fee-for-service system. So they would just pay for the volume of claims that come through.
When did we enact managed care in Illinois? And what do you think of not having managed care in Illinois? Was that a thought? And as another one, how do you think managed care is working in Illinois?
Well, I'm a huge proponent of managed care. I believe that managed care has the opportunity to help provide care coordination to Medicaid beneficiaries and help them get the right care at the right place and at the right time. So I am a big supporter of managed care. I think we want to make sure that as we take a look at what's going on in the Medicaid program, we address the things that are not working and build on the things that are working. So there are instances where some parts of managed care are certainly working, and some of the plans continue to do really exemplary work around making sure that Medicaid beneficiaries are getting much better care coordination. But there's the opportunity to improve that. And the opportunity to improve that is what we've tried to address in this RFP. So we spent a lot of time in this RFP talking about the integration of physical and behavioral health, because many of our Medicaid beneficiaries have significant behavioral health needs that we want to address. We talk about being able to have those managed care entities work with us around what we call our integrated health homes, which is what we believe is going to lead to enhanced care coordination. So we've really taken what we believe is the things that were working in this program, but certainly added a lot of enhancements that we believe will make managed care work even better.
Yeah, I believe in the philosophy of managed care, and I think that it could do well. I just haven't had a lot of I'd say, positive responses about how well it's doing. So with that, you believe that the new RFP will correct those problems? And will you have accountability measures in this? And whereas if they're not delivering and for their patients, that they would be penalized?
Well, I do think that one of the reasons we are going through this is that we believe that there is an opportunity to make it better. And as you know, the people at HFS, and certainly I do, we care about what happens to people that are in this program. So this is about trying to make this better. We will focus on quality metrics. There were a couple of quality metrics that we've heard from some of you in these hearings that you want us to include that we don't do today. So for example, dental quality metrics have come up. That's something that we will be included in our quality measures going forward. We also have been asked to include some very specific measures for children with special needs because we don't have robust quality metrics there today. And we will also need to include some additional quality measures with respect to behavioral health, certainly since our focus is on the integration of physical and behavioral health. So the opportunity we have here is to make this work better. And that is the work that's before us and what this team is fully committed to doing.
You know, the problem, I think Washington and President Obama did a great thing of getting the ACA. And managed care is there, but there's still a lot of people that's not coordinated. There's still a lot of people that still have not met their primary care home. And I don't understand, will this help? Will this new RFP help make sure that we gather all those people so that they could get into the coordinated care? I know providers right now, and I know individuals still, they've been enrolled, but they haven't met their primary care. They haven't been to their first doctor's visit yet. And this has been out for a very long time. How do we deal with that? Are you going to deal with our providers and MCOs going to be working together better under this RFP?
They absolutely will be working together better in this RFP. And that's a critical part of what we're doing with the RFP between providers and MCOs. And as I said, the integrated health homes, which is all about trying to make sure that there is a true medical home for individuals. And as you said, Representative Ford, there are about 650,000 individuals that have come into our Medicaid program as a result of the ACA expansion. And we know that 25% of the individuals that are in Medicaid represent about 55% of our costs and with behavioral health issues. We also know that a small percentage of individuals drive an even greater, percentage of our costs. So I do think that the thing that we should not lose sight on is that this RFP and what we're doing is about working to enhance the care coordination that beneficiaries are getting. For those that aren't getting that today, being able to get them to those providers. Right. And a lot of it, Representative Ford, is also going to be about education. We have to do a much better job of working with entities around helping individuals in Medicaid to work with them to understand you can go and get help before you get sick, and having a focus on prevention and not just waiting until individuals are sick. So we believe that this will help significantly in terms of driving the work that needs to happen between MCOs, providers, and certainly our community-based providers and our health centers that all need to work together to improve those outcomes.
So the emergency room visits are still up. And so has that been taken into consideration when you have individuals that's still using the emergency rooms as their primary place to receive health care? Is there some type of coordinated effort that we could use when people check into an emergency room where they are automatically linked to their primary care home?
I think our hospitals and certainly our entities work better. But one of the things we've asked for is, in the 1115 waiver that we're trying to get from the federal government is to do a much better job from technology perspective to be able to have systems that can link individuals and know when a person shows up at the ER or accessing care in a very different way. So I will say it's a combination of things we're trying to do around changing Medicaid and making it work. And that's a combination of this RFP, the Health and Human Services transformation we're trying to do with the waiver, and the integrated health homes that we think will lend to this greater collaboration and care coordination that needs to happen in managed care.
And the last question, so the contract, I think you say that people have to turn it in by the 18th, or you select by the 18th. When will a contract be awarded, and when will the contract be signed?
So the requests for proposals are due on Monday, May 15th at 12 noon. The process has transparency, so anyone who wanted to know who those bidders are would be welcome to show up at 12 p.m. at HFS and would know exactly who submitted a bid, because that is one of the requirements. So that's transparency again around what's going on. So that's on Monday, May 15th at 12 o'clock. After that, we go through an evaluation process, and we are scheduled to identify and name individuals that win the proposal by June 30th. After June 30th, there is built into the time frame a brief period for protest with the expected effective date of contracts for new entities of 1/1 of 2018.
When?
January 1st of next year.
And you don't see it, this is not a political by any means question. Do you see it being, could it be a problem for us legally signing a contract if we don't have a budget?
Well, we're actually spending quite a bit of money today, Representative Ford, without a budget. So I do think from our perspective, we always indicate that any contract is subject to appropriation.
It could still go up. I understand the consent decree, but there's still going to be other.
Yes, and Representative Ford, all of the contracts that all of our agencies execute always indicate that they're subject to appropriation, but as I'm sure you know, this department operates under a consent decree right now with respect to Medicaid.
Thank you.
So I don't want to interject myself, but I will. So just to clarify the question Representative Ford just asked, so these contracts that you're going to issue to the successful awardees of the RFP will all be subject to appropriation?
Every contract that we sign at HFS always include a provision that says that things are subject to appropriation from the General Assembly. That is the current contract that we have with managed care organizations and everybody else in the department
Just
today.
wanted to be clear. Representative Mussman for a question.
So thank you, as always, for coming and helping us understand this very complex situation. And I appreciate the other representatives' comments about the need to reduce and simplify the number of players for everybody involved. But I think I am a little bit concerned, I guess. I hear a lot of maybe advocacy around the idea that competition is good. Competition drives down consumer cost. Competition can drive up quality. Do we have any concerns about reducing competition when we narrow down the number of the number of people who will ultimately get these contracts?
We don't, because what typically happens is that if a managed care plan is going to have more beneficiaries, they are able to give you a better price. So no, I don't have a concern that this is, quote, driving down competition, because typically what happens is that if there are more beneficiaries, you're able to spread your administrative costs over more individuals. So I don't think that we will not have competition. I think we will continue to have competition, and we will certainly continue to have choice. So those are the two things that will continue to be in this program, and no, we don't have any concerns about that at all.
So I guess as far as regards choice, maybe you can help me understand. If out of the pool of MCO providers that we have today, if you're not one of the lucky few who wins a bid, I guess my question is, and I don't know, Will you have enough business in every other arena, especially when you take into account that we haven't paid you and we don't know if we will ever pay you? Will those companies be able to stay open? And therefore, at the point in time when this contract ends and it has to be reopened to new bidders, will there be any new bidders? Or are we essentially kind of creating a pool of winners and losers somewhere into the future because there's nobody else to bid?
Well, I think the way that it typically works is I don't know whether or not, well, first of all, I should say, I don't know who's going to bid. That will happen on Monday. But when it's all said and done, we expect that there will be several entities who bid. Whether entities who don't, quote unquote, win continue to be in business is not something that I have any visibility around one way or the other. But I do think that there will be a sufficient enough entities who bid on this contract, as I said, to continue to preserve choice for Medicaid beneficiaries that will be robust choice in this program.
So the Medicaid clients will be able to choose between services of these multiple bidders no matter where they are in the state. They will not be left with one choice because they happen to live in Cairo, but if you live in Chicago, maybe there's enough overlap that you might get to choose between some people.
No, Representative Mussman, I mean, as a matter of fact, you can't have managed care if you don't have choice. So the requirement from the federal government is that you have to offer Medicaid beneficiaries a choice in order to have managed care. So of course we had a situation in Central Illinois where we only had one plan remaining because there wasn't sufficient choice. So those individuals were moved back into fee-for-service. So the way that this is structured, there will absolutely be choice for Medicaid beneficiaries from Chicago to Cairo.
Okay.
Or Cairo, as I call it.
Sorry. Do we see that other states are also, now that MCOs are not the newest thing under the sun, are they also starting to reduce and limit their contracts?
Many of them have. So there is great variability in terms of the number of MCOs that exist in states. But yeah, most states, I would say, I don't know a state that doesn't go through a competitive process, Representative Mussman. So that is generally the way in ordinary course of business in terms of procuring these kinds of services.
But do you see that they're expanding the number, or do you think they're contracting the number?
Most of them are, I won't say most, many of them are contracting the number. But as I said, it varies as you go from state to state.
Okay, thank you.
You're welcome.
Representative Belloc, then Flowers.
Thank you very much, Mr. Chairman, and thank you, Director, for coming to the meeting. I just want to say thank you for all your expertise, your professionalism, and your thoroughness in running the department and in answering the questions every time you've come. You've always had, every answer. You hardly ever have to look to the left or right for anything, answers from anybody else. And moving forward, I wish the Comptroller were here, and I'm going to send her this because I respect the Comptroller very much, but this document that shows that in every aspect, as you said, in the managed care for the 10th, from 1997 through 2006, 2008, 2010, 2012, 2013, 14, and 16, we have used the purchase of care process in managed care, dealing with managed care, correct?
That is correct.
Thank you. And I think another important question that when we went over it with the Comptroller, when she kept talking, and we all, certainly everybody here agrees that we have to have a budget. I mean, there's no doubt about that. But I think she kept, I want to say your answer to the question when one of the other reps asked you about, did you feel that there was going to be savings within the way this is moving forward with this, change? And you said that you felt that there would be savings as to how it is now. Is that correct?
That is correct, spokesperson.
Right. So I think that lends itself as to, I mean, in my opinion anyways, as to why the administration wanted to move forward with this in order to, I think, save the way we're trying to help with the managed care program and serving the most important people, the Medicaid population, with continuity of care, the medical home, access to care, quality of care, all of that. I think that if you can do that at the same time in redoing this managed care program and still expect savings from it, then that would be what we would want in the state of Illinois. And I just appreciate all the work that everybody has put into it, especially in all the work that you and DHS and DCFS have done with the 1115 waiver at the same time at the beginning of the year, and the integration of physical and mental health. And again, in this program also, because I think that that's really important, and that's something that everybody on this committee, I think, has wanted to see more of also. So thank you very much. I appreciate it.
Thank you, Leader Belloc.
And Representative Flowers, and then Andrade.
Thank you, Madam Secretary. I want to also take this opportunity to thank you for your professionalism and your expertise and truly your thoroughness. I just have a couple questions. Are we expanding the number of managed care providers from the previous testimony that you gave? I thought it was being reduced to 5.
No, what we have today, Representative Flowers, we actually have 12. And in the new RFP, we will be, there are what we call 2 options, option A and option B. So in the first option, which is statewide, there will be between 3 and 5 entities. And then for Cook County, we say that the department can award up to 2 additional contracts. So we could have up to 7. So no, we won't be increasing from 12. We will be reducing the number of managed care plans that we have in the state.
You're going to reduce from 12? Reduce from 12?
That's correct, Representative.
Okay. So now, and you mentioned also that people in managed care will have choices. If your managed care plan over here doesn't have it, you can go over there. So there is no network as far as in-state and out-of-state?
Well, this is all for in-state. Although we do, from time to time, have managed care or Medicaid beneficiaries who might have to go across the state to get care, but that's typically in our border areas. So if you were in the Quad Cities, you might have to go across the state line. But this is for Illinois. This is for in-state. So if you are in Cook County, for example, Representative Flowers, as a managed care, a Medicaid beneficiary, you will have the ability to have choice of up to potentially 7 choices.
In Cook County?
That's correct.
Have you ever thought about just implementing single payer?
Representative Flowers.
Yes.
I know that's your passion.
Yes.
I really do.
Yes.
I've thought about it.
Yes.
But that would really be up to the General Assembly to decide.
Well,
what
I tell you what, I'm glad you said
beneficiaries
that.
should do.
I am so glad you said that, because now I would like for you to put this on pause. But seriously, when you think about what it is that you're doing and at the time that you're doing it, right now, there are so many fires in Washington, D.C., we don't know where to start. And even in the midst of the chaos, I heard the president mention getting back to the health care bill. And when I think about managed care today and the managed care of the 90s, I know is different, but I see them as being the same. Because again, managed care companies do have a fiduciary responsibilities, not only to the MCOs and the insurance companies. So I just see monies that could be going toward the patient, the care of the patient, but it's going toward the insurance companies. That's number one. and I don't know how close the networks are together, but having to travel the distance, I heard the comptroller mention 60 miles, and then I heard you mention about there is a limitation on the distance in which you would have to travel by federal law. Can you elaborate on that, please?
Yeah, Representative, we are very much, and we'll make sure that as we take a look at these contracts, that we satisfy network adequacy requirements. We have an obligation to do that. When you're downstate, the distance that Medicaid beneficiaries have to travel would be farther than what would be in an urban setting anyway. But we are going to be paying very close attention to what happens with respect to how long you have to travel for care and what those standards need to be. And they've been included in the RFP, but network requirements around network adequacy and the distance you have to travel for providers are things that we have to report on, and we'll be reporting on to all of you in terms of what's going on in this program.
Well, I'm glad you said that. Under the previous administration, I put forth a task force because when we had the SMART Act and we implemented the managed care for the aged, blind, and disabled, the task force number one was never implemented, but I was always curious as to how those people fared, because I do recall getting calls from doctors stating that they had not seen their patients. And a lot of them were complaining about how far they had to travel and all the problems that they had trying to get to that particular doctor. And once they got there, because we were talking about the aged, blind, and the disabled, the proper setting, the bed that would have, that the patients were accustomed to, that was being lowered for the handicap, or the assistance that was being given for people that was incapacitated, it wasn't necessarily at these new offices that they were forced to go to. And so it was really an inconvenience for the patient to go, and the doctor didn't have the wherewithal to hire someone else to help these particular patients. So I don't know if you factor that in. And like I said, the last bit of information that I got, that a lot of patients had just became discouraged, and a lot of doctors had not seen their patients. But I want to bring you to another matter that's really concerning to me, and I don't know if it's been addressed or if it's going to be addressed. But right now, we're talking about people that's on Medicaid. And we also know that people on Medicaid are also required, if they're on, they're required to work. Certain people on, it's not called Medicaid, but it's called
TANF.
Pardon me? TANF, yeah. So if you're on TANF and Medicaid, you're required to work. And even if you're not required to work and you're just on Medicaid, you still have to go through this redetermination. People with pre-existing conditions and going through this redetermination, do you see that there's not the continuity of care, or going through the redetermination and you're just on Medicaid, like a senior citizen, chances of their income or their status changing is far and in between. But yet, there has been the delayed and the deniedness of the services because the redetermination has not been complete.
Excuse me, Representative, just 1 second, please. Representative Feigenholtz in the chair.
And I'm hoping, because I'm sure you're aware of the problems that's going on in Decatur with the senior citizens and what's going on all over the state in regards to the redetermination and the lack of access to care that these people are getting now. And so I'm just trying to imagine, what is it going to be like with fewer Medicaid managed care providers?
Well, the number of managed care providers doesn't impact the redetermination process at all. So the redetermination process is
May I just clarify this?
Yes.
You're right, it doesn't impact it, but right now there's more providers, and there are a lot of people that's not getting their redetermination in a timely fashion. And when it shrinks and those same people are not getting their redetermination, I could see there's going to be more people going to fewer providers that would probably would cause a crowd out because of the process. Is there a possibility? Can you see that?
Well, I'm the first to say that we want to continue to improve on how we do redeterminations. The redetermination process is one that's required by the federal government. I think we all want to make sure that people who are on Medicaid are people who are really eligible for Medicaid, but we do know that with respect to individuals, as you said, Representative Flowers, like seniors and others, their status really doesn't change. So what we've tried to do with respect to that population is figure out a way that we can work with our long-term care providers and others so that we know and they know when the redetermination is going to happen and have some more visibility around that so they can help us with the redetermination process, because we don't want people to lose their coverage through the redetermination process. So it is one of those processes that we continue to do a lot of work on. Actually, Dr. Huggett, who Representative Ford recommended to us as a part of our Medicaid Advisory Council.
He told me.
He is so over us in terms of working through ways to improve this, and we don't go through a Medicaid Advisory Council meeting without Dr. Huggett reminding us of the ways we need to continue to focus on with respect to redetermination. So we are going to continue to make it better because we can, and really focus on those populations where we know their circumstances haven't changed that much, and how we improve the way that we do redeterminations for that group of individuals, Representative Flowers, because it's a very valid criticism, and we want to continue to make it better. And I would welcome, and we always welcome, any new suggestions and ideas in terms of how we can improve that redetermination process.
Well, may I make a suggestion, please? Again, because it really concerns me, because I've had a few problems with people with a pre-existing condition. And so there needs to be a grace period. There needs to be a period where these people, despite the fact they're going through the redetermination process, and sometimes through no fault of their own, it could be because of what's going on in Decatur or what's going on in these local offices, the paperwork constantly being lost, or whatever's going on. But it's causing hardship on the customers that need to have their paperwork. There needs to be a grace period. And however length of time that the redeterminations are behind, that needs to be the grace period. And if there's a finding that there have been these substantial changes, then you deal with that. But in the meantime, there's people out here with pre-existing conditions and people that's dependent on their medicine on a regular basis. So, but to know that the amount of money based on TANF, that too needs to be addressed. I don't know what the max is under the federal government, but that too needs to be addressed, because what we're doing to people on Medicaid, we're further suppressing them. We're saying that if you're on Medicaid, if you're on TANF, if you ever try to do better, if you try to get an increase, you're going to lose two things. You're going to lose your Medicaid card, and you need that, and you can't afford to go to the market because the market isn't there anymore for the most part, and you're going to lose your insurance.
And so
Excuse
no
me,
one
Harris
should be,
back in the
no
chair.
one should lose their insurance because they got an increase in pay, a very minimum or a very short time increase in pay. So those are the things that's really concerning me. And the safety net hospitals. Have we concluded that all safety net hospitals will be involved?
Well, every safety net hospital that participates in the Medicaid program today has the ability to continue to participate in the Medicaid program.
Now, when you say they have the ability to continue to participate, please explain that to me. Because
that means that all of the safety net hospitals will be able to contract with the managed care plans in the state.
Okay, because the last meeting, I think there were some concerns that the safety net hospitals thought they would be left out of the equation.
No, they are not left out of the equation.
All right. Thank you very much. I appreciate you.
Thank you, Representative.
Representative Andrade, then Manley.
Thank you. Thank you, Chairman. Director, I have a couple questions. Why was the request for proposal written in such a way to include some MCOs but exclude others? In particular, what was the policy reason for allowing a government-operated or a minority-owned MCO to operate a Cook County-only network, but not allow a not-for-profit MCO that currently operates a Cook County-only network that serves mostly minority patients to not bid to continue to provide a Cook County-only network?
So, Representative, we drafted the RFP in what we believe were the best interests of the people of the state. That entity is a potential offerer, and I will not talk about that in the context of this hearing.
Did someone approach you to include those two?
Well, Cook County Health and Hospital System is one of the largest hospital systems that we work with in the state of Illinois. So certainly we believed from a public policy perspective that it was important to include Cook County Health and Hospital System in the RFP process. In addition to that, the governor firmly believes that a minority-owned entity should have the opportunity to bid on this contract as a part of the RFP process. So it was the policy from a Medicaid perspective that we allow that to happen.
So is it any minority-owned operator that can just bid in Cook County?
That is correct.
So any minority operator, it doesn't matter if they're not existing now, but if they go and apply, or does this minority operator almost get guaranteed to be accepted into the program?
They're not guaranteed to be accepted. What it allows under the RFP is the state to be able to award, in addition to the 3 to 5 contracts that will be awarded statewide, the ability to award up to 2 additional contracts in terms of Cook County only bids. And that can either be a county-owned entity or a minority-owned provider that meets the definition of a minority-owned provider as established in this state.
So the minority operator could be established in the state. It does not have to be established only in Cook County.
That is correct. The way that the minority-owned entity is established, it's a statewide definition.
No, I'm saying that.
So it's a definition that is.
No, I'm saying the minority company can be based in McHenry County.
They could
Doesn't
actually
have to be based
in Michigan.
Michigan.
They could be based anywhere, as long as they met the definition of what a minority-owned organization is under the terms of the RFP.
Okay. So no one who approached they approach you or the governor's office to allow only minorities to participate and not for profits?
No one approached us, Representative.
Okay, so it's a decision by your department.
That is correct.
Okay. Currently, at what percentage have we moved 50% of Medicaid recipients to managed care? That was one of the goals. At what percentage are we at now?
Today, we are probably roughly at maybe 61 or so percent, Representative.
Okay. And the FHN member hospitals are saying that if FHN does not get their MCO contract renewed, safety net hospitals will close. Is the department concerned about the potential for a significant reduction in access in some of the Chicago's most underserved communities because of potential hospital closures as a result of this arbitrary MCO contraction?
I will say that the department has concerns for all safety net hospitals in Illinois, and we work with them all the time.
Thank you. Also, the last question I have, will this result in any lost funds to the safety net hospitals, owners of the family health network?
I could not answer that question, Representative.
Because if they don't win, or if they win, or they don't win, or just...
I can't answer the question in terms of whether or not it will represent a loss to the owners of FHN.
Okay, thank you very much.
I'd like to recognize one of our Senate colleagues who's joined us. So welcome, Senator. And we'll go now to Representative Manley and then Representative Willis.
Director Norwood, thank you. Just briefly, I'm trying to wrap my head around, we're doing this RFP, and we're not going to pay these people. Does it say that in the RFP that, hey, by the way, when you bid, we're not going to pay you because we don't have a budget? It doesn't say that, does it? But yet we're going to go forward with this knowing we can't pay them. To me, that seems, I mean, it seems in the spirit of doing things on the up and up and transparent and with respect to people that are trying to conduct their business, we should be telling them that. I don't know, maybe we'll have a budget by May 15th, but I don't know. Does anybody think we'll have a budget by May 15th? I hope we do. What are we telling these people that we're inviting to bid? Why are we going forward this when we clearly cannot pay them?
Representative, we pay Medicaid providers today. So we're talking about the same
They're all paid. Every single one of them been paid up to date. Everybody's paid?
I think you're aware, Representative, of where things are with respect to payment.
I do, and that's why I'm saying I think it's irresponsible for us to continue with this RFP if we cannot pay the people we're inviting to bid.
Well, I think that's an assessment that the offerers will have to make in terms of whether or not they submit a bid to the state of Illinois on May 15th.
Okay, thank you.
And Representative Willis.
Thank you very much, Mr. Chairman. Director, I have a couple of major concerns and questions about this. You did provide us with the reason that you felt that you did not need to go through procurement code for this. And I actually have some major concerns on that. What premise do you feel that this, which is in essence the biggest procurement, at least certainly in my time in the House, to do this RFP without going through procurement code and instead being able to do it by what is the title? Provider, service provider type thing. Purchase.
I think that would be the document that I provided at the beginning of my testimony, Representative.
But those that showed much smaller purchases than what you're doing now as this big bulk. Maybe all in all, but each one was a smaller purchase at that time than this would be.
It represents, Representative Willis, the way that this department has always acquired services from Medicaid beneficiaries in the state of Illinois under managed care. So the program that we have today, you will notice, represents several entities that we contract with, and that is absolutely the same way that we purchased care for the program that we have today.
All right. Would you be willing, one of the things, though, you talked about earlier was that, in your estimation, this service would not really go into effect till January of 2018. But then this contract is going to be for 4 years after, which means that would be going into a new administration. Is there any concern about what happens if the new administration wants to take a different aspect of that instead of what we're looking at right now, or you're looking at going towards?
No, Representative, because all of our contracts give the department or a provider the ability to terminate a contract with sufficient notice.
And what
so
do you
if
call
a new
sufficient
administration
notice?
decided that they had a different policy direction, they would be able to alter those contracts, terminate those contracts.
Okay. We're going, and currently you're saying RFPs are all due on Monday. That's obviously when you're going to be opening up the bids. Do you know how many bids you have at this point? I mean, do you have a bunch of envelopes so that we look? What's going to happen if, because of our current financial climate, you don't get enough bids? You know, people don't have enough faith in us as we're looking at this not coming in. You know, it's all subject to appropriations being paid. What's going to happen then? Are you going to retract the RFP at that point if we don't have adequate fair bids?
I think that's an assessment, Representative, that we will have to make on Monday when those bids are due to the state.
Have you received any yet, or you don't know?
I talked to our Chief Procurement Officer as of yesterday. No bids had been received.
No bids had been received.
That is correct.
Okay, and so we're looking at that. I'm going to bounce a little bit on things, and Senator Sandoval has given me a couple of questions to ask of you. One of the ones is going back to the Family Health Network. If we go and that doesn't come through, do you anticipate us losing jobs certainly through the minorities and the safety net hospitals, St. Anthony's, St. Bernard's, Norwegian? What's going to happen with that since they are not part of the scope of the RFP, that they can actually feel that they can do an adequate bid? What do you anticipate happening to those safety net hospitals, and not just access to care, but the jobs that are associated with the people in those communities and those hospitals?
Representative, my expectation, and I think what will happen, is all safety net hospitals contract with whoever the managed care entities will be for the city of Chicago.
So you don't anticipate any stop of access to care or anything in those safety net hospitals?
I do not anticipate any access to care for Medicaid beneficiaries in the city of Chicago.
Okay. My final thing would be that right now we've been, there's actually, I'm sorry, not quite final, two things. One, we've been talking and we have seen on the news inundatedly under our current president about the way he is attempting to overhaul Medicaid plan and all that. Don't you feel that this is not the best time at all for us to be going and overhauling our own Medicaid here when it's in such a precarious situation? And you may feel that it's not overhauling, but in my opinion, if we're reducing from 12 MCOs down to 7 MCOs, we're overhauling our plans.
Representative, I believe that we have an obligation to be good stewards of the taxpayer dollars, no matter what the Medicaid plan looks like from Washington. So this state, regardless of what happens in Washington, will still be spending through its Medicaid program one of the largest share of state dollars. So from my perspective, it's important that we are very vigilant around how we spend those dollars, notwithstanding what happens in Washington.
But wouldn't it be more difficult to do that if we're going to lose federal money? We're going to be then reducing access. I mean, I truly am mostly about access to care. I think that's what we're looking at, that we're going to be hurting if we're reducing that. We know that that's something that we're constantly fighting right now, and safety net hospitals are just barely hanging on by a thread. And if we're going to cut them out, and I think in a lot of ways this RFP does cut them out, don't you feel that we're going to also be cutting out those that depend upon those safety net hospitals?
Well, I don't think we're reducing access to care in this RFP, and frankly, we wouldn't release an RFP that we believe reduced access to care.
Okay, but I think some of my colleagues have stated to you that you are one of the most profitable or I wouldn't necessarily say profitable, making money, but the most successful safety net areas are in the Latino and Hispanic communities under Family Health Network, and they've been carved out of being able to, the way the RFP was drawn up.
Well, as I said, every entity that is able to meet the terms of the RFP that we put forth will be able to submit a bid on Monday.
Right, but I'm stating that I believe the RFP parameters were not done in a way that had open competition and allowed those that have been successful in doing managed care in the communities, they've not been able to fit the parameters of it. With that being said, I respectfully ask you to retract the RFP at this point in time, because I do feel that you are going to be cutting out some very significant MCOs that have been successful throughout the state, and I really do have a true concern on access to care to our citizens. What else I need to add? Thank you very much.
Senator Sandoval, having traveled all the way from the Senate chamber to come to the House, so for the record, I'm told I need to identify Senator Martin Sandoval for the purposes of identification for the clerk, and you have some questions, Senator.
Thank you, Chairman Harris. Director Norwood, I've been very public about my disposition and my opposition to this, your efforts to privatize Medicaid. It's very simple that as a result of your action, that your department's action has taken in regards to this purchase of care exercise, you will put Medicaids in the hands of a handful of for-profit CEOs and Governor Rauner and yourself, and with no oversight of the legislature. Is that the outcome that you want for taking care of the poor in Illinois?
Well, Senator, I disagree with the statement. So it's certainly not the outcome that we're going to have in the state of Illinois.
Are non-for-profits going to be part of the scheme of the model to take care of the poor, the African-American Latinos, as a result of this purchase for care exercise that you will conclude in just a couple days?
I don't know who will submit a bid for this RFP, which is due on May 15th. So I will have to see who submits the proposal by May 15th, which is the deadline for submission.
Do you support non-for-profit MCOs being part of the model and strategy to take care of Medicaid patients in Illinois?
I support any MCO, for-profit, not-for-profit, who's able to help us to develop a quality managed care program in the state of Illinois for our most vulnerable citizens.
So your boss, Governor Bruce Rauner, has made it time and time and again. He's made statements about keeping jobs in Illinois, spurring economic growth in Illinois, supporting the entrepreneurial spirit of investing in minority businesses. And you, as an African-American woman in Illinois, knowing the plight of growing up in the neighborhoods, perhaps of North Lawndale and Inglewood, La Villita, Pilsen, what will you say to the professional staff that work at St. Anthony's Hospital in North Lawndale, Little Village? What will you say to the professional staff at Norwegian and St. Mary's in the Humboldt Park area? What will you say to the professional staff at St. Bernard's and Mount Sinai? These are African American and Latino professionals that will lose their job as a result of your action to privatize Medicaids and put it in the hands of private CEOs.
I'll say this, Senator. I'm trying to be very respectful.
You don't have to.
Of the question you just asked.
You could say what you feel,
Director
Norwood.
At the end of the day, we've designed this program that I am confident will deliver quality health care to African Americans and Latinos in the state of Illinois. So I will say to those hospitals that I hope that they will continue to do so as they do today, contract with the managed care plans that they will be working with to deliver that care.
So for the fact of the matter is that you're going to take 30% of the revenue away from St. Anthony's in North Lawndale. Those are African American, Latino staff, professional staff, and employees. You're going to take 30% of the revenue away from Norwegian American and St. Mary's. You're going to take 30% of the revenue away from St. Bernard's and Mount Sinai. I don't know how you're going to sleep well at night, knowing that you are putting on the unemployment line African American and Latino professionals, middle-class families that have worked their entire lives at these institutions, and you're going to shut them down.
I'm going to sleep at night because I come in here every day doing the job that needs to be done to take care of Medicaid beneficiaries. And I will say to you, with respect to Sinai, we rolled this RFP out at Mount Sinai. And Sinai is an integral partner of this state and has been for a long period of time. So at the end of the day, I sleep confidently knowing that I come in here every day and work hard for the people of this state and the people that are Medicaid beneficiaries.
In your Purchase of Care Act, you require that one of them be a minority. And if one of the MCOs that is selected is a minority, will you require that minority firm to return back to your agency if they choose to sell their lives to another source?
Well, first and foremost, in the RFP, we don't require any. We basically indicate that a minority-owned entity has the ability to bid on the RFP. So that is what the requirement is.
So you don't care if a minority-owned MCO wins, participates in providing health care to
We wanted
the
to
poor?
afford the ability to a minority-owned entity to participate in this program, which is why we've included that.
So in your Purchase of Care Act, you require that one of them be a minority, and would you require, if a minority wins the selection, would you require them to come back to your organization if they intend to sell their lives? Otherwise, it's all a farce.
Anytime anyone gets to do anything with respect to Medicaid lives, they have to come to the department. So that would apply to a minority-owned entity or anyone else that would want to work to do that with respect to Medicaid beneficiaries.
So if a minority entity is chosen, you will make it a requirement to replace that entity with another minority MCO?
I'm not sure I understand that question, Senator.
Very
I
straight.
will make it a requirement to replace.
If you award one of the MCOs, which is a minority-owned MCO, if they choose to sell their lives during the course of the contract, will you require them to come back to you and only sell their lives to another minority firm?
Any entity that sells their Medicaid lives is required to come before the department to seek approval to do that. And that is a minority-owned entity or an entity that's not minority-owned.
But if it's a minority-owned entity awarded, would you require that the proceeding awardee be a minority firm?
It's a speculative question, so I'm not sure I have an answer for you, and I would prefer not to speculate. Suffice it to say, if any entity sells their Medicaid lives, they are required to come before the department to seek approval to do that.
So then you would support a minority-owned MCO selling their lives to a non-minority firm, flipping the lives, selling it to a majority firm overnight without any encumbrance on that decision?
We would have to examine any circumstance, Senator, at the time it came before us. So I won't speculate in terms of the department's response because we don't actually have that scenario in front of us for consideration.
Director Norwood, and so why did you decide to go outside of the procurement process? You know, why didn't you decide to go with, to stay within the procurement process and go with an RFI or go with, within the procurement code? You decided to step outside of the procurement code and go with some Purchase of Care Act action. Why did you do that?
I'm glad you asked that, Senator, because we just shared with this committee the process that the department used, which is the same process that the department has used since at least 1997. So that handout gives you the jurisdiction that the department used in terms of this RFP is consistent with the laws of this state, and it is the process for purchasing managed care services for the Medicaid program. So I did not decide to go outside of a process. We actually stayed within the state requirement and the process for purchase of care in the state of Illinois.
Just going to make a statement to this committee, and I appreciate the allowance, Mr. Chairman. I just think that it's been a history of African American Latinos working together to save Medicaid in the state of Illinois. We have worked arduously to ensure that Medicaid is a program that serves the poor and the less fortunate. And I just think it's ironic that it'll be in the hands of an African American director to dismantle the years of work that the black and brown have taken on over the last 100 years, and you will have torn it down just with a stroke of a pen as a result of your action. Thank you for your time, Mr. Chairman.
Thank you, Senator. And I just a couple questions, final questions are more technical in nature for you. As I've read your letter a little bit more closely, the last line, it says, regarding persons who are going to actually evaluate the bid, it says the department will not be releasing names of the individuals evaluating the proposals or recommending contract awards. And it says that that is standard practice in state procurements. Is that a legal requirement, or is that just an option you've chosen to avail yourself of, not to reveal the identities of those who evaluate or recommend contracts?
Now, in that particular case, Representative, I will have to seek counsel because that's actually came from our lawyer. So I will ask Molly Zito, who is General Counsel for HFS, to respond to that.
Thank you.
Good afternoon. It's my understanding that it is not technically, do you need me to state my name? Molly Zito. It's not technically in the code, it's just been standard practice for, and I think the CPO's office is the where we started that practice and continue it today.
So there's no impediment, legal impediment to releasing the names of those who evaluate and award the contracts. It's just your choice not to inform us.
Well, we don't release the names, but we actually, after the whole process is done and the awards are made, it is my understanding from our agency procurement officer that we would release the scoring. It just wouldn't have a name on it, would have a number on it.
Do you intend to notify the Inspector General, or have you already, of the employees who have worked on, developed, and or analyzed the RFP, or who will evaluate or award contracts to ensure that the revolving door policies are triggered and to ensure that an outside entity is double-checked for potential conflicts?
Yes, the evaluators have been notified about our the conflict of interest provisions as well as the revolving door and their obligations under those to talk with our ethics officer at the department and then as well as the OAIG.
So when those notifications are made to the Inspector General, do the names of those who awarded, evaluated, and developed the contract become publicly known?
I do not know the answer to that question, sir. We can look and get you an answer back.
Okay. I'd appreciate getting an answer back because, again, if this is a choice the department is making not to let the committee or the public know who's been involved in this process, that's different than if the law precludes you from doing it, and it sounds like this is a choice.
That's my understanding. I will go back and check the law, but my understanding is.
I mean, that, this is one of the things that raises questions and eyebrows, I will just tell you that. Have any employees within your agency been asked to sign non-disclosure agreements of any kind related to the RFP?
Yes. Again, there's a confidentiality form that each evaluator must sign.
And who has to sign a non-disclosure agreement?
Everyone involved in the process, in the evaluation process. It's standard procedure at the department with every procurement.
So it's standard procedure. Is that right, required by law, or is that a choice of the department?
In the RF, let me grab my stuff. I know the section of the code. It is, yeah. It's in the code under the evaluation. It's 44 Illinois Administrative Code 1.2015 section, and it talks about where the evaluation committee members shall be determined by the state agency tailored to the particular solicitation and include, as appropriate, technical or other personnel with experience to ensure a comprehensive evaluation of officers. Evaluation committee members must not have any conflicts of interest or apparent conflict and must commit the time. There's also a provision where it talks about the confidentiality. Yeah, each member, and so we mirrored the purchase of care procurement after the code, and so that is where the confidentiality
So it says
comes
the
in.
department shall determine, it was the language I heard you read. So I guess my question is a confidentiality statement required by law, or was that a choice of the department?
It was in the procurement code, and when Molly and the team went through the procurement code, we tried to mirror many of those provisions. So we have required all of the members of the evaluation team to sign a confidentiality agreement.
And could we get a copy of the agreement just to see what it says?
Absolutely. We can make sure that our CPO, who is Lynette Schaefer, gets a copy of that to Louis so that you can have
And
it,
if you
Mr.
could then,
Chairman.
just so we don't have to take time
Absolutely.
here reading through the statute, Ms. Zito, if you could send us a link to the citation so we could
Absolutely.
figure out, was this required or was this a choice? Okay, but I can't write it down that fast. Just one last question that came up, and again, this is just another case in point of without having independent oversight, as things can become fuzzy or things can be interpreted to be fuzzy. And I'm referring back to a question, the second questioner was Robin Gable, who was asking about the issue of those providers who are contracted with MCOs who subsequently are not successful winners of the bid that will be opened Monday. And the question was about whether for persons who submit bids, whether their intent to pay their providers would be part of the review process. And the answer was that you expect those reviews will be taken into the account, will be taking into account the issue of provider non-payment when those reviews are considered. But you've also said you're not going to be part of the review and evaluation team. So knowing that those things will be taken into account by those who are making the reviews, it just opens the question of, why would you know what the reviewers are going to take into account if there is a recusal from that system?
You know, Representative Harris, because they're required to submit financial information. So as a part of the RFP process, every offeror has to submit information with respect to their financial ability to meet the terms and conditions of the contract. So we have a team of individuals at the department that will be reviewing specifically the financial proposal as a part of the RFP process, and they have been brought to the table because they bring to the review process that financial acumen. So it doesn't require my comment for that to happen. It's a part of the process for reviewing the RFPs. And it is correct. I will not be an evaluator, nor will any other person at the department who has ever worked for a managed care organization that is capable of bidding on this RFP.
All right, I think that wraps us up. Ladies and gentlemen, thank you for your patience and time. And we add Representative Hernandez to the role. And now we will proceed to Jordan Powell, the Vice President of the Illinois Primary Health Care Association, Samantha Olds-Fry, the Executive Director of the Illinois Association of Medicaid Health Plans, Amy Meek from the ACLU Women's and Reproductive Rights Project, and in lieu of Rob Carr from the Illinois Merchants Association, Garth Reynolds, who is from the Pharmacists Association. So, Mr. Reynolds, if you could come up. And since Ms. Olds-Fry is sitting at the end of the table, let's start with her. And if you can offer your testimony, all of you, and then we'll come back for questions, I think would be the best.
Good evening. My name is Samantha Olds-Fry, and I'm the Executive Director of the Illinois Association of Medicaid Health Plans. Thank you for the opportunity to testify today. We've had a lot of conversation about Medicaid managed care, and I think it's really, and the RFP, and I believe it's really important to talk about how we've arrived here. Specifically, I have a unique perspective in my time on staff and watching the SMART Act unfold and what the Medicaid program looked like when it was fee-for-service. There were many constituents of yours that would end up calling you or legislative staff in turmoil and in confusion without somebody to sort of hold their hand and walk them through the red tape that is healthcare. They needed to have their hearing aid repaired, they needed to see a specialist, and they didn't know who to call, and they turned to you. And while you are wonderful legislators, your role is not as a care coordinator. And the fee-for-service system relied on you and on the administration to function in a role that they just weren't meant to function in. And that is why we turned, in part, to Medicaid managed care. And I am a firm believer that care coordination is the right answer for this program. It is right for the 3.2 million people that rely on this program every day. I think that as we go through this transition and as we look past at lessons learned from the past transition, we must keep those people in mind because that's what we're here for. Our goal is, of course, to make providers happy, to streamline this process for them. But we will never do that at the expense of quality care for our Medicaid members. They are our primary focus. And some examples of that, we often hear about streamlining prior authorization requirements or eliminating them altogether. And while that sounds nice on paper, I think I need to just take a moment to talk about what prior authorizations are and what care coordination looks like and what that means for members. And a simple example of that is we had a health plan that received a prior authorization requirement for a Hep C pharmaceutical, and the health plan looked at that and realized that the doctor prescribing it wasn't looking at the new clinical data. And they were prescribing something that wasn't clinically appropriate, something that wouldn't have been caught were it not for prior authorization. People like to say that prior authorization is for cost, but really it is ensuring that there is clinical appropriate care, and that's important from our perspective. Also important to note that health plans offer additional benefits above and beyond what HFS is able to do. Most health plans have preventative adult dental care, and the reason for that is we believe in prevention. We know that we must invest in the care for these 3.2 million people in order to reduce costs later down the road. You acknowledge fully that this transition has been challenging. We own a piece of that. We recognize that and are working every day to improve that. Here are some things that we are doing right now, even with the RFP going on. We are streamlining credentialing process and streamlining and educating on billing guidelines to ensure that no matter what plans are operating in 2 months and 4 months and 2 years, that we are improving that process for providers because they're an important partner in this goal. As we move through the new transition through the new RFP, we believe first and foremost we all must focus on the families and Medicaid beneficiaries that rely on this program. It is their security, it is their health care, and we must think of them first and foremost. And to that end, IMHIP is working with community organizations and some professors to develop a health literacy campaign that's focused on the lessons learned from focus groups of Medicaid members, not of providers, not of lobbyists, but of the Medicaid members, the people that rely on this program. And we are going to use those lessons learned to educate social service organization frontline staff, because there seems to be a lot of confusion with that staff level, and that's where our Medicaid members turn to understand the Medicaid program. And so we think we need to improve that level set of education. We also want to echo that all health plans, all members of IMHIP are committed to a smooth transition with minimal disruption to our Medicaid members. We're all committed to safety net providers. They are a strong and valuable partner in this program, and we would be lost without them. We do have specific recommendations for this rollout as we move forward. We expect, as HFS has always done, that there will be a more detailed timeline once the bids are announced, or once the awardees are announced. In the past, HFS has done a great job of saying letters will go out week by week, and here's the zip codes they'll be mailed to, and we have no reason to think that they won't provide that more detail as we get further along. But in all of that communication, we need a clear statement in every letter that goes out and anything that health plans do or legislators that make it clear that Medicaid members still have access to health care. This is confusing and a challenging time, and that statement must be on everything, that no matter what, you still have access to health care. We believe strongly and differ with the department on this, in that we think a single formulary is the wrong approach for Illinois. Illinois has tried a one-size-fits-all program, and it didn't work, and the people who were hurt the most were the 3.2 million people that relied on the program. Today, the HFS fee-for-service formulary covers a single tablet regimen for HIV, AAA. They tend to leave off long-acting behavioral health drugs that we believe are crucial in care coordination. Most health plans offer nearly all single tablet regimens and offer most long-acting behavioral health pharmaceuticals. We do agree that HFS has heard about that concern from doctors, but what we think is more important than the concerns of doctors are the benefits of Medicaid members. We've also done research on other states, and we have found that this change will cost the state $100 to $200 million. $100 to $200 million going to pharmaceutical companies. If we want to invest that money in Illinois Medicaid, we have some ideas that they go to behavioral health providers, children specialists, and honestly specialists across the board, and dentists to increase access to health care. We also think that there needs to be robust education of providers, of DCFS providers, of any new health plans. And we are committing as an association to monthly meetings to update legislative staff as this rolls out, to answer any questions you guys may have, to update you on the notifications that have gone out thus far and where we are on the process, so that there is that transparency and that oversight that you guys want and deserve. Thank you for your time.
Good evening, and thank you, Chairman Harris and members of the committee. My name is Jordan Powell. I'm the Senior Vice President of Public Policy and Governmental Affairs for the Illinois Primary Healthcare Association. At IPHCA, we represent 51 federally qualified health centers that treat over 1.3 million residents at 360 sites throughout the state. As you know, and as Sam stated, managed care has come with its challenges, but I'd like to first acknowledge the attempts that have been made to improve it within the RFP. Namely, IPHCA is pleased with the state's decision to reduce the number of MCOs, as this has proven to be an administrative burden for FQHCs and other providers. We are also pleased that the state is pursuing a single vendor to credential providers, and we believe that these changes are being made as a result of Director Norwood and her staff's willingness to listen to and respond to the concerns of various healthcare stakeholders. Attempts to improve Medicaid managed care have also been made by the General Assembly through legislation passed last year to hold MCOs accountable and make managed care more consumer-friendly, and we thank you for that. However, moving forward, we believe the state must take on a greater role in holding plans accountable. Providing transparency over their operational performance has been a great start, but in the short term, this has done little to prevent the disruption of patient access to care. A recent example of this occurred in Macon County, and this was brought up briefly earlier in testimony, where 2 hospitals and their affiliated specialty providers canceled their contracts with the only MCO in the area, meaning there were no specialty providers in the county that would accept patients from the local FQHC. This was problematic for a number of reasons, but the biggest reason was that even when the FQHC was able to find out-of-town specialty providers to see those patients were unable to arrange transportation to actually get the care that they needed so much. And I want to be clear that I'm not being critical of hospitals or specialty providers that cancel their contracts with health plans. I think there are legitimate reasons for them to do so. I'm also not being critical of all health plans. As you've heard today, the health plans are owed an enormous amount of money, so I can understand some of their constraints. But I want to touch on contracts with FQHCs and how it's a little bit different for us. If we're dealing with an underperforming MCO, we can't simply cancel a contract without impacting our patients because those lives actually belong to the health plan. So if we were to cancel a contract with an MCO, our patients would be unable to stay with their medical home, which is problematic for patients who have already built a relationship with their provider and support team. So we believe that patients should have the choice to remain with their primary care provider when a contract is terminated between an MCO and FQHC. Finally, I would like to specifically address 2 more areas within expanded Medicaid and the RFP that should be considered by the state. First, since the state is limiting the number of health plans, there will be several current health plans whose contracts with the state will end December 31st. The state must ensure that patients who will be reassigned to the successful bidders remain with their primary care provider to prevent disruption of care. The algorithm that is used to determine how patients will be assigned and reassigned must be transparent. And second, and this was brought up also earlier in testimony, and I'm not sure we've received a clear answer on this, is that the state must ensure that the unsuccessful bidders fulfill their obligations to reimburse providers for amounts incurred prior to January 2018. I know we've raised this with HFS. I believe they're formulating a response, but I think it's critical that we get a response on that as soon as possible. Thank you, and I'd be happy to take any questions at the end of this panel.
Good evening, and thank you for the opportunity to testify today. My name is Amy Meek, and I'm a staff attorney with the Women's and Reproductive Rights Project at the ACLU of Illinois. We work to ensure that everybody in Illinois has access to the full range of reproductive health care, particularly marginalized populations. And the ACLU also has a long and proud history of defending religious liberty while also vigorously protecting women's rights and reproductive freedom. On March 9th, we wrote to HFS to raise critical concerns about coverage of reproductive health care services, including abortion care, in the context of the recent HFS RFP. As the state is increasingly shifting Medicaid enrollees to MCOs, it's more critical than ever that HFS take steps to ensure that all patients can access medically necessary health care. First, we're concerned that HFS managed care contracts, including the draft model contract in the RFP, expand an MCO's right to claim an objection to paying or arranging for the payment of certain covered services beyond what's currently provided for under state law. Under the Healthcare Right of Conscience Act, a healthcare payer can only refuse to pay or arrange for services based on a conscience objection that is documented in formal governing documents, such as a mission statement, bylaws, or ethical guidelines. So HFS should require the submission of such a document by any MCO that's objecting to paying for or arranging for covered services on conscience grounds. We also urge HFS to take the steps necessary to ensure that if an MCO refuses to pay or arrange for care based on a conscience objection, that there will be appropriate procedures in place to assure that patients are not denied care as a result. HFS must create procedures to ensure that patients enrolled in objecting MCOs can still access covered services when needed, and they must require MCOs to prominently include this information in member handbooks, for example, so that patients know how to access these services when they need them. Second, HFS must correct its misleading and inaccurate managed care contract language and guidance regarding abortion coverage. Since 1994, Illinois has been under a court order in Doe versus Wright, which requires the state medical assistance programs to cover abortion services necessary to protect a woman's health. This addresses the gap in coverage that's created by the Hyde Amendment, which bans the use of federal Medicaid funding to cover abortion services, except in cases of rape, incest, or life endangerment. However, HFS managed care contracts, including the draft model contract in the RFP, repeatedly cite outdated state and federal regulations that would only cover abortion services when necessary to save a woman's life. Accordingly, most MCOs have issued handbooks for their members and their providers that include misleading and inaccurate guidance about the scope of abortion service coverage. As a result of this and other needless obstacles to care, Illinois now provides so little coverage for medically necessary abortions through state Medicaid that the Guttmacher Institute recently concluded the state's likely in violation of its longstanding court order. We urge HFS to also take affirmative steps in evaluating RFP responses and in the draft model contracts to ensure that MCOs have adequate provider networks and quality assurance standards to offer access to all covered services, and that includes abortion care. For example, we've become aware of women who need hospital-based abortion care to address a serious health condition, but whose MCO didn't contract with a single hospital that offered abortion services. HFS must take steps to ensure true network adequacy in these situations. Thank you for the opportunity to testify today, and we urge HFS to address these important issues as it moves forward with this process.
Good afternoon, Chairman Harris, Chairwoman Gable, and members of the committee. My name is Garth Reynolds, the Executive Director of the Illinois Pharmacists Association and a practicing pharmacist. We thank you for your interest in this important topic and concerning managed Medicaid and the current RFP process. We're glad to hear that the MCOs have started to receive funds from the Comptroller's office to provide payments to the providers who have already dispensed care and provided care. But we are still hearing delays every day from members that we are still not receiving payments or the lack of payment altogether, and we hope that this process is rectified soon. We'd like to provide additional comments concerning the RFP process itself and the model contract that is part of the RFP. We do commend the requirement for the MCOs and the PBMs that are required to follow the preferred drug list established by HFS. We feel that the conformity as the patients move within the program, if they are moved from plan to plan, that there's consistency and non-disruption of their therapy. We see under the current program where we have had member pharmacies describe situations to us of their experiences of trying to obtain medications in a timely manner with the processes that are currently established. It's also worthy to point out the provisions in the model contract that prohibit the MCOs from negotiating for further rebates from drug manufacturers, and that this conduct should be reserved only to the state. We do recommend a change that for not utilizing the reimbursement methodology that is currently in practice based on MAC pricing, and to utilize a more proposed and recognized NADAC or National Average Drug Acquisition Cost modeling that would provide that would also add, instead of a dispensing fee, utilize a professional dispensing fee for each of those prescriptions. This model is what is being adopted across the nation under the current federal guidelines for the covered outpatient drug rule and should be mirrored into the managed Medicaid program as well. We'd also like to see an option for 90-day community dispensing option available for our Medicaid recipients, as other patients of ours have the option to be availed to them today. We hope, in addition to payments starting to go out once we have a budget to the MCOs, that we look at establishing a prompt payment to providers from the MCOs. And there is some language in the model contract for 90% for 30 days or 99% of the clean claims. So we want to make sure that there's a clear process and delineation of what a clean claim is before we go through with the contracting. We're glad to hear that from the director that she wants to preserve that Illinois is any willing provider, and we want to make sure that there's adequate network availability to all of our Medicaid recipients throughout the state, and that they have the ability to use their local pharmacist as their personal medication expert provider. We also would like to see changes or at least adherences to proper step therapy and prior authorization provisions that are based on true medical evidence-based evaluation and not fiscal or rebate concerns. We're not continually seeing this process in the current environment today. And we'd like to see the establishment of processes that fully utilize pharmacists as direct care management healthcare providers, not only in the areas of medication adherence, but medication optimization and pharmacist-provided care services, in addition to services such as immunization health and contraception health. Pharmacists are not being fully utilized to our expert and educational provisions under current law and current design of the program. And we can help assist not only with the MCOs and HFS in meeting the prevention and treatment quality measures that are in the RFP. And we can look at other states that have established this type of situation of utilizing enhanced services such as Iowa, North Carolina, Washington State, and Wisconsin. And we really appreciate the ability to preserve the access to pharmacists, since pharmacists are the most accessible healthcare providers in Illinois. And we appreciate the committee's time to allow IPHA to provide our comments today, and look forward to any questions as we go forward in this process. Thank you.
Thank you, ladies and gentlemen, for very clear and concise testimony. I just have a couple questions for each of you. And start again with Ms. Olds. So on the single formulary issue, did I hear you say that, for instance, in the HIV arena, the only combination therapy on the formulary is a tripla?
Correct. Based off of my research with organizations like the AIDS Foundation of Chicago.
How broad or how comprehensive then is the individual therapy formulary?
So I can get you that analysis. I do not have.
I know how many drugs there are out there to treat this special population, and to say there's only one available on our state formulary if all the others aren't there in single pill regimen, we want to know that, and what's the cost to that? I mean, that's sort of crazy. And then when you were talking about behavioral health, explain the omissions in the behavioral health arena.
Yeah,
again.
so, and I can get you from our pharmacy team, but we believe strongly that long-acting pharmaceuticals, they're newer in general, and they are more costly upfront, but we see that they decrease hospitalizations and medical costs in the long term.
Especially for people with behavioral health conditions, the thing we hear over and over and over again, we all sit around in these rooms and talk about how important it is to deal with substance abuse and mental health problems, and then our own state decides that the formulary it's going to offer 1/4 of our population, many of whom struggle with behavioral health problems, is lacking in drugs that actually treat behavioral and mental health. What the hell are we thinking? We're going to do this, we're going to then send people out onto the streets, and then we're going to expect a different result, and then we will come back here and have more hearings into why there are problems with people with behavioral mental health and substance abuse conditions in our communities and in our prisons. This just seems, as my grandpa would say, bass-ackwards. So you also brought up, I think, a program. Were you talking about the same thing that Mr. Reynolds was referring to on the drug rebate issue of channeling money from drug rebates into prevention and other programs, or did I misunderstand?
We were talking about different things, but
so what
similar
was your thing?
In the sense that once there is a single formulary, we can no longer any negotiating power we may have to get a better cost for the Medicaid program overall is gone.
Okay, so by going to a single formulary, we have given up the ability to obtain hundreds of millions of dollars from drug companies that could come back to the state and fund other things. And that sounds like another great triumph.
Yes, and we have researched that from other states have done this recently.
Yeah.
And we have studies from the year before this was implemented to the year after, and they saw their pharmaceutical costs increase by roughly 100 million or so. And those programs were smaller than ours, smaller than our Medicaid program, and so that's why we are sort of saying 100 to 200.
For those members who are not familiar with how, and this is the manufacturer side. So I'm not, when I say pharmaceutical guys, I'm not talking about you. But when we as a state negotiate with pharmaceutical companies, there is a price that we pay, there is a fill fee that we pay, and then there are the side deals with the drug companies to get back huge rebates. And that amounts to hundreds and hundreds of millions of dollars to the state of Illinois that we collect every year that we do not then have to burden our taxpayers with. And it sounds like with this deal, we have just lost several hundred millions of those dollars, and now we will have the opportunity to ask our taxpayers to chip in more because the state just lost what would have been free money in its pocket.
And to be fair, the state can still negotiate rebates. It's that health plans won't be able to negotiate additional rebates and invest those savings in behavioral health and other areas. As you know, a lot of health plans pay, over 100% of the Medicaid fee schedule for certain behavioral health services because their rates aren't, they don't meet the needs of the provider community, and so we want to increase access and our ability to invest
That's right.
those savings.
Every time I hear this proposal described more, it gets better. So, Ms. Meek, you sent a very lengthy letter to the department, or you and Ms. Schaefer of your office sent a very lengthy letter to the department in March explaining the many concerns you had with the reproductive rights clauses in both the RFP and the contract, including the fact that they wrote RFPs and contracts and didn't even know what current law was, but wrote that in. Have you ever had a response to that letter?
No, we have not.
So you have written a letter describing in detail, a couple months ago to the department, a letter that says not only do they not know the current status of the law, they are not following it, and they're putting at risk women's reproductive rights. Now, when we had our hearing in the end of March with the director, she did say she had never gotten that letter. If those of you who remember it, and we gave her, I went over and I physically handed her a copy of the letter, so we know they've now seen it, but they have not responded.
That's correct. We have not gotten any response from them.
And so should they go ahead with this, incorrect interpretation of law people are submitting their bids if someone submits a bid between now and Monday. So people are going to be submitting a bid based on an RFP which has certain imperfections in it that have not been cured. What do you do then if people respond and they file an RFP based on incorrect law? If they have a model contract that includes incorrect law, what would you as the ACLU probably do in that instance?
I don't. There are a variety of measures that we could take. We certainly would like to work with the department on this issue, and we would like to work with the state on this issue. We see this as an access to healthcare issue, and so we want to see this resolved. We want to see MCOs with appropriate guidance about what they're supposed to cover. So we're looking forward to working with the state and in whatever way is most effective to educate the state and MCOs about the scope of the law.
I hope they would take you up on that before you go to Plan B, as they say. And then, Mr. Reynolds, you again brought up prompt pay.
Yes.
So there's in the RFP there's conditions for prompt payment.
Well, there's condition for payment to the providers within 30 days for 90% of what's considered to be clean claims.
And so I want to stop you right there because
okay.
the word, if it's a clean claim, that seems to be a phrase all of us have heard over and over again. How many times do you have a problem with a clean claim when it's being submitted?
I was going to say, my professional experience, I've rarely have ever had a prescription go through that didn't have a concern of some type that I needed to have additional information on.
So the current RFP does define a clean claim, but we are working with the department to provide education of providers of specifics and examples. You know, you wouldn't put that in a contract, but examples of this is what you need for pharmaceutical claims, this is what you need for hospital claims, et cetera. And the RFP and the model contract does not contain a provision that, to the best of my knowledge, around the prompt pay interest or the timely payment interest that providers should receive from a health plan. That is because statute requires that. So the insurance code says that within 30, we begin paying interest within 30 days of a clean claim. It's worth noting that health plans do not receive prompt payment interest until 90 days, until the state is 90 days overdue. So we are paying interest before the state is paying interest. Which is obviously a challenge in this fiscal environment.
Questions from other members? Well, seeing none, ladies and gentlemen, thank you for your time and attendance. At this point, the House Human Services and the House Appropriations Human Services Committees will stand in recess to the call of the chair.